Hello, good morning, everyone. No call and response? Okay, all right.
It's last day.
All right, guys, we'll get this rolling. Welcome to the final day. We're gonna squeeze every last drop of energy out of you and out of ourselves that we have left. I'm Jacob Mormon. I'm a thoracic surgeon at the University of Mississippi.
I'm Ann Wynn. I'm a GI doc at Baylor Scott & White in Dallas.
And we will be your entertainment for the morning. Real quick, just because this is a little different every year, how many are surgeons in the room? Heavy. All right, and gastroenterology? Okay, a little bit. I feel like some people raise their hand twice. Raise your hand if you raise your hand twice. Okay.
Hybrids.
I feel you. I'm a little bit like that.
And
Go ahead.
I guess how many people, just curious from a flip standpoint, how many people are, first-time flippers, having used flip, interested in learning about more? Okay. And how many people are flip fanatics? You guys have it, you guys love it, you want to learn more of what it can do for you?
Speakers don't raise your hands.
We all know what you all are.
Okay, good. So we're a little proceduralist heavier, maybe 60-40, but otherwise a nice mix of experience, so, okay.
All right, well, we'll get started with our first talk. Our first talk is Flip Protocol and Basics, given by Abe Khan from NYU.
Oh, and just a little shopkeeping, we'll maybe have brief questions between talks if time allows. If not, there'll be considerable time to ask the speakers questions during panels and breaks, and so we'll get them in one way or the other.
Okay, thank you very much, Jacob and Ann, for that introduction, and thank you all for coming and spending your Sunday morning with us. To learn about flip. So my role was really to talk about the basics of the protocol and the balloon and what we term flip panometry. For those of you that are not familiar with it, we're going to go over it in a lot of detail. And I think, with my talk, there'll be a little bit of repetition, which I think is always good for those of you sort of learning a new technology. And for your advanced users, I apologize if there's too much repetition, but I don't think it'll be too harmful at this point. So these are my objectives. We'll go over the functional lumen imaging probe or flip panometry protocol, at least the most well-described current one, because this is really something in evolution, as we've seen with manometry over the years. And then we'll talk briefly about the utility of a flip panometry diagnosis in the workup and treatment of esophageal motility disorders. And I'll have a couple very brief cases. Later on in the agenda, there's going to be a lot more time to dive into complex cases. So what is FLIP? So the functional lumen imaging probe, it's a balloon tip catheter placed during endoscopy. And what it uses is what are called impedance planimetry sensors mounted on this catheter. And during a specific protocol, which we'll review in a lot of detail, the balloon is filled with conductive fluid and the voltage is measured across these paired impedance sensors to ultimately give you cross-sectional area and thus diameter inside the lumen. Now, if you look at the picture of the balloon there, there is a pressure sensor as well, so you can end up getting area divided by pressure, what is called distensibility. Okay, now the original proposed utilities were to really look at this at the EGJ alone and look at motility disorders in GERD, and as you can see on the bottom right, if you have a condition like achalasia, you're going to expect to have a low distensibility index, which is that area over pressure. And if you treat the patient successfully, you would expect that DI to actually go up. Now, there is still an 8-centimeter balloon, which you'll hear about throughout the course today. I'm going to focus really more on the longer flip balloon, the 16-centimeter balloon, because that gives you much more sensors to look at the smooth muscle esophagus and also look at contractility, which I'll go through. Okay, now how I really perform a flip study is I do the endoscopy first, I then, at least the diagnostic portion, I then put in the flip balloon, okay, and then I actually put the scope back in, make sure I've confirmed my position that's reached into the stomach, the balloon, take the scope out, and then you have the balloon alone inside the patient, and you have your monitor on the outside to look at your measurements. Okay, now what was realized by the investigators using this longer balloon is that when you put it in there, inside the patient and fill it up as per a certain protocol, there were patterns of contractions that were observed over time that look eerily similar to manometry. So I'll show you in a few slides how that looks in a short video. Now, these contractions are presumptively not, of course, from primary peristalsis like manometry, but they're from secondary peristalsis and other mechanisms. And we know secondary peristalsis serves a major role in bolus retention and reflux already. And we also have to say that the response to distension is complex within the esophagus and depends on the location and extent of it. When we're utilizing this flip balloon, it's a particular device, and we're filling it up in a particular way to look at patterns that we're now starting to understand pretty well. Okay, now what you'll hear a lot about throughout today, in the sessions is a normal flip equivalent to a normal manometry? And what I mean by a normal flip, I'll go over in a lot of detail, but the contractile pattern would be called repetitive antegrade contractions. And then at the EGJ, you're looking at normal EGJ distensibility. Now the difference is the colors are based on diameter on the flip study at the top, whereas on the manometry study at the bottom, the colors are, of course, based on pressure. And there you're looking at primary peristalsis and normal LES relaxation away from a catheter. A little bit different on manometry than in flip, which is a dynamic opening process, looking at how the EGJ opens as you fill a balloon with pressure typically increasing. Okay, now what is the exact protocol we use currently? Now this is the most well-described protocol in the literature. Again, this is something that's going to evolve over time, we expect, but currently this is the most well-described, well-published protocol. And this is where we put the balloon 1 to 2 centimeters into the stomach. We initially fill it to 30 to 40 milliliters and ensure the position. Okay, then you fill it up to 50 milliliters, and then at 50, 60, and 70, ideally you're spending, up to 60 seconds each. I think at least 30 seconds is going to be a high-quality study of looking at measurements at each of those volumes. Now, what measurements are you getting? Now, for those of you that are unfamiliar with this, this is where the repetition is going to come in a lot during my talk, but these are the measurements you're going to get to make your ultimate panometry diagnosis. So ultimately, it's not that complex once you get familiar with it. So you're going to take at the 60 milliliter fill volume, the measurement of EGJ-DI. Now, ideally, you're going to take 3 measurements and then take the median of that at the pressure peak, which, as I'll explain, is usually in sort of the beginning to mid point of the contraction. When the contraction is occurring, the EGJ is opening quite well at that point. So you take a median of 3 of those DI measurements at the 60 milliliter volume. Then at the same time, you're looking throughout the entire 50 to 70 volumes at your contractile response pattern. And we're going to go through all the different responses. The one that's shown there is the very obvious rack pattern, okay, where you're getting good contractions at actually all the 50, 60, and 70 volumes. Okay, and then you're at the same time going to look at what is your maximum EGJ diameter at either 60 or 70 milliliters, and usually it's at 70 because you've put in more volume into the balloon, and you're going to just look at what is the point where it reaches its max diameter, and then take that number, and that's going to be a key part of your diagnosis. Now, you can do these measurements in real time. There are abilities to pause your study in real time, but now there are also other options for analysis afterwards. There's, a customized program with open source download, and the new Flip 300 system allows you to actually do some investigations and go back into the study after the fact as well. Okay, now before I show you videos, I wanted to show just some static images, of course, for the beginners in particular, of how we would sort of make our measurements. Now, if you look at the top and you look at that 60 milliliter, that's the current volume you're in, and then you also have a current pressure, that 44.3. Okay, we have just filled up to 60 milliliters, so we went from 50 to 60. The first 5 seconds of filling, and perhaps up to even 10 seconds, you're not going to use that. It's too dynamic and reactive of a situation. So you're going to sort of wait till the next contraction. Now you see at the far right, we have paused, and that blue arrow, okay, we have paused the measurement right sort of at the first third to middle of the contraction, typically where the pressure has gone the highest, and that's where your EGJ is going to be the most open. And you see the red circle there, we're highlighting what is the DI and diameter at that point. And you can see it's 5.12 the DI and the diameter is 17. Okay, so you're going to mark those numbers down, and then for the next contraction, that was your first measurement, you're looking at the next sort of pressure peak of contraction, again pausing it there, okay, and seeing what is your DI, what is your diameter. In this case, it was 6.09 and 18.7. And then your third measurement here, okay, similar numbers, okay, your pressure peak of the contraction where your EGJ is opening the most typically, okay, under that pressure, you have a DI of 5.91, diameter of 18.2. And then you take the median of that, right? And you're really focused at the 60 milliliter volume at the 3 DI measurements, and your median would have turned out to be 5.91. Okay, so that's how you would take your DI, but of course you're also going to be focusing on the contractile pattern at the same time and the maximum diameter you're going to look for as well. Okay, now if we go to just a short video, this is one of my videos, okay, of how it's going to look like on the screen after you filled up. So I've shortened this video where we're at the 60 milliliter volume, okay? So we're watching here. Now you're seeing not really a lot of long contractions here, so it may be a little bit challenging to know exactly when you're going to take your DI. But if I sort of wait for this next contraction, let's see, to come in, okay, so we're going to skip this one, and let's wait. So you'll see the pressure at the top. Sort of going to wait. The pressure perhaps right here, that contraction is coming down. I probably was a little late on that. But if you look at my DI at the bottom, okay, it is going to be over 2. And you're going to see it's 3.08. So the numbers are a little bit low at the bottom. Now if we pause it again, okay, let's see. I'm going to roll it again. That contraction has come down. We're going to wait for the next one to come. Okay, let's say right about here. Now the DI is clearly normal down there at the bottom. It's around 4.4 at the LES. So again, that looks like it's going to be a normal DI. As I'm going to go over shortly, over 2 is going to be considered a normal DI here. So I'm pretty happy with how this EGJ is opening. Okay, now when the actual study gets to 70 milliliters, I'm also going to be focused on the maximum diameter. I can still be focused on that now because the diameters are pretty high. If I look at the diameter here on the next contraction, it's actually 17.7 at the EGJ. Okay, and something above 16 is going to be considered normal, as you'll see when I go over the normal data. Now, this is how the Flip 300 system looks. There's some advantages here in terms of optics. You actually have a highlighted portion where you can have a few sensors at the bottom near your EGJ. Actually, let me roll that again. Highlight the numbers a little bit higher where your most narrow area is. And you can see some of the DIs there as the contractions are going down are clearly normal, okay, in the 6, 7 range, and the diameters are 16, 17, 18, no matter where I'm going to pause it. In this case, I'm pausing it. DI is 5.2 at the EGJ, and the diameter is 18.6. Okay, so that's how the system looks and the interface. And as I said, with the new system, you have some more ability to look afterwards as well. And do your analysis when the study is done a little bit more conveniently. Now, what are some other protocol key points? For those of you that are beginners, you know, this can be sort of served as a reference slide, but I did want to go over these before I get into the panometry diagnosis and classifications. So what is contractility? Because as you know, if you do manometry, there's some measurements of DCI and these kind of things, what's weak, what's failed, what's normal. So what is a contraction in Flip? Well, currently it's being defined as at least a 3 centimeter axial length contraction, okay, with the diameter going down a little bit. Okay, now when I mentioned where you do the DI measurements at 60 milliliters, you know, I had already mentioned this. You want to try to do it at the upslope of the pressure peak. usually towards the start to the middle of the antegrade contraction. As I said, you want to exclude at least the first 5 seconds after filling, as there may be some reactive activity. If you do have hiatal hernia, sometimes you'll actually see two pressures there at the EGJ. So what do? Similar to manometry, you can look at both. You can actually do the DI at the intrinsic LES and do the DI at the diaphragm as well. And then people always ask, well, what if I'm in the 60 milliliter volume, I just get one contraction? How am I going to take the median of 3 DIs? Well, in that case, just report the available DIs if you have your contractions. And if you have no contractions, you can just take 3 separate measurements of the DI, usually spaced about 10 seconds apart. Okay, now one thing to keep in mind, especially in a baggy dilated esophagus, is sometimes the pressure is not very high, and then the DI really is not very accurate when you haven't put enough pressure inside the lumen to see if the EGJ is opening. And then you really shouldn't report that DI, and you can report the diameter and pressure instead. And then one thing which is listed here on the figure, the dry catheter artifact, what is that? Imagine the balloon being squeezed by a very strong contraction. Okay, it's really cutting off those sensors above and below to really give you accurate measurements, and you might see diameters in the 30, 35 range. Those are inaccurate. It's because really you've cut off those measurements of the impedance planimetry sensors to work accurately. Okay, so now I'm going to go into sort of this flip panometry diagnosis and what we do here. So a normal contractile response, again, between the 50 and 70 milliliter volumes, what is normal? To have these, which are 6 repetitive antegrade contractions, at least 6 of them, of at least 6 centimeters in length, going at 6 plus or minus 3 per minute rate. Okay, so it could happen anywhere between the 50 to 70 range. It could start at 50 and then wear off. You know, if you have 6 of them, you're going to call it racks based on this current analysis paradigm we have. Okay, now what are other contractile patterns? If you look at the top right image, if you have just a few of these, or even one, antegrade contractions of at least 6 centimeters in length, that would give you borderline contractile response. Okay, now the manometry diagnosis for that patient, you can see, was ineffective motility. And then on the bottom left, what if you just have a few of these 3 centimeter length axial contractile response patterns? You know, that's going to be called impaired or disordered contractile response. That patient you see at the bottom left ended up, because their EGJ was not opening well and the DI was very low, as type 2 achalasia. And then on the bottom right, what if you have almost no activity at all? You don't really meet even those 3 centimeter length contractions. That would be the absent contractile response. And that patient on the bottom right, who ended up having a normal DI, ended up having absent contractility on manometry. Now, spastic reactive is the other contractile response pattern, a little bit more tricky to diagnose. There's 3 ways you can diagnose it if you have one of these 3 things. Either a sustained occluding contraction, otherwise known as SOC, which, is yet another mnemonic we have in the esophagus. And what is that defined as? A contraction of it greater than 10 seconds at the EGJ and the body with a pressure above 35, non-propagating. So it's not really peristaltic, okay, going down. And then this is extremely rare, okay, repetitive, retrograde contractions, where typically this is greater than 9 contractions per minute going backwards up the esophagus. That would also give you spastic reactive. And then if you have a sustained LES contraction, okay, SLESC, I guess you would say, okay, that would be a contraction of the LES independent of respiration, greater than 5 seconds, with not associated with an antegrade contractions. And oftentimes, in achalasia patients, you will see that, and it's just a higher pressure happening there, where it's squeezing down at the balloon on the at the LES area independently. So then what do you do with all your numbers ultimately? So remember, you have your median DI at 60, you have the highest diameter reached at the EGJ at 60 or 70, and you have your contractile pattern, right? Well, the first 2 you use for your EGJ opening assessment, okay? And that's where the number 2 for the DI is extremely important. And for diameter, you want it above 16. So if you go to the bottom, normal EGJ opening, or NEO, okay, is a DI at least 2 and a diameter at least 16, okay? And then if you go backwards to the top, what is reduced EGJ opening? That would be a DI under 2 and a diameter max under 12, okay? And remember, these are people going to the 70 milliliter fill volume. Okay, and then everything in between is borderline. There's some push to, further classify the borderline or BO as Brio or Bino, okay? I'll leave it up to you if you want to go into that, but mostly, realizing if it's reduced or normal is most important, especially when you have multiple testing modalities you're looking at. Okay, and then ultimately, you take your EGJ opening classification and you add that with your contractile response pattern, and then you come up with your ultimate panometry classification. I'm not going to go through all of these. You can use it as a reference, but normal would be normal EGJ opening and either that normal contractile response or borderline contractile response. So think about it. You might just have one antegrade contraction between 50 and 70. As long as your EGJ opens above 16 and DI is at least 2, you're going to end up having a normal panometry diagnosis. Okay, weak, it's sort of obvious. You have normal opening, but you have the weaker patterns. Obstruction with normal contractile response, I see this most often when there's subtle strictures or stenoses, where you have normal contractions, but you actually have Rio and reduced opening. Obstruction with weak contractile response, that's where you have the clear reduced EGJ opening in terms of your numbers, okay, and the weaker patterns, that often is seen in achalasia. Spastic reactive is really that spastic response with any opening, and then everything else is inconclusive. Okay, now you'll hear throughout the sessions a little bit more about the data behind this, really a little outside the scope of my talk, but I'll go through very basically what it showed. And when you do these metrics of EGJ opening, 687 patients and 35 controls were looked at, and 241 patients had reduced EGJ opening, and all these patients had manometry, Chicago 4.0 as well. And of the patients with Rio, 86% had the new EGJ outflow obstruction diagnosis or achalasia on the Chicago 4 manometry, so that's pretty good predictive value. And then 203 patients with normal opening, 99% had normal EGJ outflow per Chicago 4.0. And then putting that together with contractile patterns, this was a study looking at 539 symptomatic patients who all had conclusive manometry diagnoses compared with 35 controls. 156 patients ended up having that normal flip panometry, and 95% of them were either normal manometry or IEM. So that's pretty good. So what you could say out of that study was if you have a normal flip panometry, it's 95% likely you have normal manometry or IEM, okay? And then in the 202 patients who actually had flip with weak contractile response with that Rio, that reduced opening, 92% had either achalasia or EGJ outflow obstruction. So the conclusions of that study was that this flip panometry, protocol and analysis we've been talking about really parallels the Chicago 4.0 manometry classification and can complement or perhaps in some cases replace manometry. And that led the authors of the study to really talk about if you have normal flip panometry, essentially you've ruled out a major motility disorder. You likely don't need a manometry at that point, okay? And then on the other extreme, if you have that obstruction with weak contractile response, you're going to strongly suspect achalasia. Maybe you might want to still do manometry, especially for subtyping that's sort of individualized, or if you're confused about sort of the overall picture, it's not really fitting with achalasia with your other testing. Okay, now my last couple minutes here, just very brief review of cases so I can show some other brief videos. This was a 42-year-old female with a partial response to acid suppressive medications. We had planned and we do this for a lot of our patients now, if we're trying to do a wireless pH test and we're thinking maybe this patient may go down the road of an intervention, we ended up doing a flip with the wireless pH capsule placement. This was the patient's flip. So I can't speed it up here. So I am at least short, and I'm at the 60 milliliter volume. So you can see there's some nice contractile, antegrade contractions coming down. If I pause it there, sort of at the beginning of that contraction, if you look at the bottom, all my DIs right there at the EGJ are nice. The lowest one there is 4.17, and the diameter looks to be 18.5. So I'm already confident that this is likely going to be normal EGJ opening, because my diameter's already reached, above 16 here, and you can see the contractions are at least 6 centimeters, going down. What you'll also notice here is it almost looks like there can be 2 areas of narrow diameter, and that looks to be like a hiatal hernia, perhaps susceptibility to a hiatal hernia. It's not necessarily 100% proof there is one, but it certainly is making you strongly suspect it here, especially with those 2 areas you can see sort of after the contractions narrowing at the EGJ. But this is a very nice contractile pattern. You can see the numbers at the top. It's going up to 70. Do you even need to go up to 70 here? You could argue maybe you don't, because you've already seen the 6 contractions. You have your rack pattern. Your diameter's already gone above 16. Your DI is clearly above 2. So this ended up being a very normal flip panometry classification. When I did go up to 70, the diameter went up to 19.4. The median DI was 4.5. The contractile response was normal. I mentioned consider possible small hiatal hernia or at least susceptibility to it throughout the case. And my interpretation, it was normal flip panometry. The patient ended up having a positive wireless pH capsule test and was treated medically in this particular case. And then my last case, 62-year-old male with progressive dysphagia to solids and rarely liquids. An outside esophagram was potentially consistent with achalasia. Ended up getting a manometry, and in Chicago 4 was inconclusive for achalasia. I think there was one sort of weak peristaltic wave in the upright position. It was really pointing towards achalasia overall, but we ended up wanting to get a flip just to be a little bit more confident. And the endoscopy itself, you see there was little fluid retained in the lower esophagus, sort of mild dilation and only mild resistance to passing through the LES with the scope. So it wasn't clear even on endoscopy in particular. We ended up doing the flip study. Now here I'm at 50 milliliters, So, here you see the DIs are all very low, DI in the green there at the bottom, you see the numbers flashing. It's all 0.8, 0.9, 1, There's no contractions happening here at all. And since I'm at the 50 milliliter volume, I'm not necessarily worried too much about the DI just yet. One thing is, as I'm filling, especially in a potential achalasia case, I am looking at the pressure. Because ideally, I want the pressure above 20, at least 15, and it is reaching above 20. And perhaps this patient, because they're not massively dilated, the pressure is clearly adequate. Now it's filled up to 60. So now, because there are no contractions, I'm just going to end up taking 3 DIs, separately. So I might pause it here and take 1. It looks like it's 0.84, And then I'm going to play it again. A few seconds later, I'm going to take another. But I can tell you it's pretty easy because it's all about 1 or below, And what ends up happening is there are no contractions that really are adequate, and the diameter does not reach above 12. So the patient ends up having Rio, and ends up with a max diameter of 10.2, so ends up with this absent contractile response with reduced EGJ opening, and the overall diagnosis being obstruction with weak contractile response, strongly consider achalasia. Patient was given options, ended up deciding on just a pneumatic, was doing well on 1-year follow-up, and we'll see where it goes from there. So that's the end of my talk. Thank you very much.
Thank you, Abe, for setting up the framework for our course. Our next speaker's name is pretty synonymous with FLIP. We have Dusty Carlson talking about FLIP and HRM, who gets what and why.
And just hang on to your questions. We're going to get them all in here soon. And for the proceduralists, I know a lot of this is kind of some word salad, and you're thinking, but what do I do with that information? We're gonna get there too. So hang in there.
All right, well, Jacob, Ann, thank you so much for having me. AFS, thanks for having me. And yes, and sorry about the word salad. We spent a lot of time thinking about things. You know, we don't ever say actually slesk. It was S-L-E-S-C. It was supposed to be a play on T-L-E-S-R. But yeah, not everything hits, you know, a home run. So anyway, so flip and HRM. Who gets what and why? I think yeah, an important topic and one we kind of think about, and certainly another one that's evolving. So first off, just thinking about who's getting either of these. And so, you know, we see patients for a lot of different reasons. That's what gets them in the door. We do endoscopy for many of those reasons. And often endoscopy is sufficient, and we've got a diagnosis there. But more often, it is not. And we maybe have a completely normal endoscopy, or we've got an endoscopy that might look like achalasia. But we're not going to be doing POEM based on an endoscopy alone. And so we need confirmatory testing. And so that's where we use our other objective testing. Certainly we have a variety of motility tests, and we have ambulatory reflex monitoring as well for the reflex picture. You know, certain scenarios where we may use these tests and those other objective diagnoses as well, our child hernia, for example. But when we're thinking about motility testing, here's where we're looking at really FLIP or HRM. Sometimes we do need to complement those using an esophagram. Thinking motility disorder, time-barium esophagram protocol is helpful as well. But also as we're going through here, thinking that we're often never using these things in isolation, and sometimes one test alone may not give us a real confident diagnosis or confident enough to subject somebody to a invasive and irreversible type of procedure. So these complement each other. But just first off here, I'll just kind of throw out a list here of who gets FLIP, maybe, or HRM. First, I think there's a real appealing use of using FLIP during this index endoscopy and kind of using this as like a motility screen, a motility triage. Like Abe just so nicely showed, when there is a normal FLIP, chance of having a major motor disorder is exceptionally low. If you have a very abnormal FLIP, it's a good chance of having a motility disorder. And not all the time we'd be stopping there, but at least from a triage standpoint, you maybe know who needs additional testing to confirm that diagnosis. So why would you do HRM? Maybe you didn't have FLIP during your endoscopy. Maybe you don't have FLIP. That's a reasonable time to use manometry. Maybe you're using FLIP because you don't have HRM. I think also reasonable. And really, if you're thinking about some of the setup, the cost, the training of personnel to do these procedures, FLIP is very easy. Manometry, a little more complicated to do. Both obviously require equipment, both obviously require some know-how in doing them. But having FLIP and being open to sending people to other places to get manometry when they need it may be a reasonable choice as well. FLIP, I think, also very appealing for patients who can't tolerate a manometry. FLIP done during a sedated endoscopy, patients don't even know what happened. Manometry, people know what's happening. God, I feel like last year at the FLIP course, we kind of started off talking about who has done a manometry. I think maybe now's the time. Who here has had a manometry performed on them? All right, that's a good hand. Has anybody here had a COVID test done on them? Yeah, okay. Has anybody here done a FLIP or had a FLIP done on them? All right, I've done a handful of FLIPs awake. It's better sedated, at least so I've seen. I've not done a sedated FLIP, but anyway, but certainly an appeal there as well. All right, why would you do manometry? For positioning of a transnasal pH sensor. And we look at why manometry is done. This is actually the most common use of manometry in the States, and FLIP gives you measurements from the incisors to the EGJ potentially. There is the potential for the FLIP distension to actually cause a little longitudinal muscle contraction, shorten the esophagus a little bit, so I wouldn't use those measurements to place a wireless pH sensor. And this is something that manometry does provide, and if you're gonna do a transnasal pH sensor, manometry will give you that measurement. FLIP also needed for an inclusive manometry. And this is the guidance, and I think if you look at just kind of more global recommendations for the use of FLIP, this is the one that keeps coming up. There are times when manometry is not gonna be the conclusive diagnosis. I mean, manometry is not a gold standard test for esophageal motility disorders, and FLIP is an excellent complement for those inconclusive or equivocal manometries to help give us a better diagnosis. But FLIP also is not perfect either, and FLIP can also be inconclusive or equivocal. And these are these scenarios where we really need both tests and maybe even need esophagram as well. All right, when a flip is spastic, there are some spastic findings on flip that need further characterization with manometry. Manometry is a little more precise in looking at the type of spasm, the extent of spasm, and I think when we do see those spastic reactive flip patterns, there's also a chance that that patient may not have some of our classic spastic disorders that have been defined on manometry. The reason that we've called that one spastic reactive is there is that potential for the esophagus having an exaggerated secondary response. And we've seen some of those in patients with hiatal hernias, with esophagitis, with strictures, and so it is a consideration, and when we see a spastic flip, that is a scenario where we're doing manometry to help complete the diagnosis and bring things together. What about EOE? Flip, I think, has a really, really cool and appealing use here to help further characterize that, and I'll come back to that a little bit. And then when people are coming back after having achalasia treatment, this is another scenario where flip is giving us better information about the nature of the esophagogastric junction, I think being a little more helpful in directing maybe need for additional therapy. And then as I was sitting here right now, I actually just realized that I left a really kind of glaringly obvious indication and use for who gets flip manometry off of this list, but it's in the OR. And certainly for many of you, and with the talks from Zach and Mike coming up, we'll talk about using this in the OR. I think there's a great appeal there, but I apologize that I was coming at this from the who gets flip or manometry in the endoscopy suite or motility lab. All right, but as I mentioned as well, there's also a time when we're gonna do both of these tests, and that is kind of one thing to keep in mind, and often needing that also we may need to get additional testing beyond these two as well. Sometimes motility patients are complicated, and complicated patients need extra data. But in all of this, and when we have this discussion, I think we also want to recognize that these tests are not the same. I mean, it's kind of comparing, it's not apples to apples. This is apples to what I put here, a pear. Yeah, other fruit choices we could have gone with. But with flip, I mean, one, this is in a sedated patient. So there is that, obviously, a nice appeal there. But this is the esophageal response to distension. This is not a sedated patient repetitively swallowing. But so we're looking here at secondary peristalsis, what we've called a contractile response to distension. And also, we're looking at EGJ distensibility. We're looking at mechanical EGJ opening. Yes, when there is distension of the esophagus, there is some LES inhibition. There is LES relaxation that is a component of this. But it's not just LES relaxation, and so it's a little bit more of a mechanical assessment. Whereas the manometry, this is the response to swallows typically. Not always, I mean, we get basal measurements there as well, looking at basal LES pressure. But this is done in an awake patient, of course. And with swallows, we're measuring primary peristalsis. Sometimes you may see secondary peristalsis on manometry also, but at least the key tests and the test components of the Chicago classification are looking at primary peristalsis. And even here, looking at deglutative LES relaxation, the IRP is intending to measure. Also not the only thing measured in that IRP measurement, and there is a component of EGJ pressure, a component of intrabolus pressure that contributes to the IRP. So none of these things are perfect in isolation, but often because these are measuring different components of esophageal function, it provides a really great opportunity for these two modalities to complement each other. All right, but when we do look at flip and we classify esophageal motility, we do it in this fashion. Basically, you've got your contractile response, you've got EGJ opening. Abe just went through this really, really nicely about putting these things together and creating a flip panometry motility diagnosis. I think the real key here and really real high-performing kind of features are at the ends of the spectrum. When flip is normal, we see the rack pattern, we see normal EGJ opening, we see antegrade secondary peristalsis, or at the other end here, we see a complete absence of contractile response, we see reduced EGJ opening. These are really important and powerful patterns when we see those on flip. And really, I think we showed this in our study here where we looked at over 500 patients, all of whom had a conclusive disorder based on manometry in the Chicago classification. So people who had that EGJ alpha obstruction manometry, we had them get TBEs and made that conclusive EGJ alpha obstruction diagnosis independent of flip. But in looking at this, patients who had a normal flip, again, antegrade secondary peristalsis and normal EGJ opening, I mean, 95% of these patients had either a normal manometry or IEM. Clinical relevance, the actionable relevance of IEM and manometry, certainly something that's up for discussion, but high negative predictive value for having a major motor disorder. Also, I think important here is this weak contractile response pattern. I mean, this is when there's normal EGJ opening, but there is not antegrade secondary peristalsis. So this would be implying that there could be kind of a hypomotility type of scenario. You see here that actually most of these patients did end up having a normal manometry. Again, these are different factors. Patients can have normal primary peristalsis and abnormal secondary peristalsis. Clinical relevance of that is still being sorted out a little bit, but I think clinical application here, still 0% of patients here have achalasia. So an important clinical application, as I mentioned with this obstruction with weak contractile response pattern, I mean, this is the non-spastic achalasia pattern that we see on flip, particularly when the pressure is low. Higher pressure, there was a few patients in here who had type 3 achalasia or conclusive EJ outflow obstruction, but most of these patients are type 1 and type 2 achalasia. 92% in total of patients with this pattern on flip had a conclusive disorder of EJ outflow by the Chicago classification. But now, of course, we're left with these other classifications, spastic, reactive, and inconclusive flip. A lot more heterogeneous HRM diagnoses here, and this is where we need additional testing. But even thinking about where flip fits into that index endoscopy here, we can see how this can be applied initially. Maybe patients who manometry isn't going to be your next test. Normal flip, weak flip, maybe you're doing reflex testing at that point. Maybe you're at least trying empirically looking at more functional mechanisms, treating from that aspect. Whereas if you're in that triage standpoint and you see these spastic reactive or inconclusive flips, these are patients who you're going to really try to send for a manometry to get more information and help make that diagnosis. So Abe also showed this slide, how we break this down. I think we can bundle this and lump this even farther, though, looking at within these patterns here. These may be scenarios where we could defer manometry. At the normal or weak flip classifications here, there's going to be a low probability of having a clinically relevant, actionable manometry diagnosis. And then with achalasia, I'm not making any of these judgments or statements here based on flip alone. You know, flip is done with endoscopy. So you've got the endoscopy to really help complement all those flip findings. And the flip findings always, always, always need to be interpreted in the context of that endoscopic appearance. So if you do an endoscopy, the EGJ is tight, there's dilated esophagus that's full of fluid, I mean, you maybe don't even need manometry at that point or flip. You know, you're pretty confident you got achalasia, but you can put flip down there, you see this pattern, I think you've got a pretty reliable diagnosis at that point once you've ruled out anything causing a pseudoachalasia. However, the reason I cut off this box kind of halfway through that achalasia pattern here is that if endoscopy doesn't look like that, if your endoscopy truly is true normal, or maybe you've got a little hiatal hernia or something that gives you a shadow of a doubt that this is going to be achalasia, even if you've got that flip achalasia pattern, I mean, you're not done there. You know, there's a little bit of discordance, and so that's a scenario where those patients should be sent for manometry, and you're really going to complement that using the flip, using the additional testing, manometry, maybe barium esophagram, to help bring that together and make the diagnosis. And then, as I mentioned, using manometry if there's an inconclusive or potentially spastic type of flip. All right, going through kind of some more of the why now and where you would use these tests or the other. And as I mentioned with the Chicago classification, this is where the Chicago classification recommended using additional testing when you've got this EGJ outflow obstruction pattern. That's where there's findings of obstruction, elevated IRP in the two positions of the protocol, also complemented by having elevated intrabolus pressure. But even with all that, and with the clinical symptoms that help support that diagnosis, the Chicago classification working group wasn't confident to say that, okay, you can go ahead and use invasive therapies to treat that patient like achalasia at that point, but you should get additional testing. Flip is among that additional testing. And we tested this. We did a study looking very specifically at patients using the Chicago classification version for EJ outflow obstruction diagnosis. We looked at these patients relative to their flip findings. And we showed that if we use this, and we did this not in a vacuum, these patients were treated based on other data as well, clinical response, clinical presentation, oftentimes barium esophagram. But patients who had these abnormal flip findings, this was spastic reactive flip or that achalasia pattern flip, but using that in the context of the also abnormal Chicago classification version for manometry, these patients did not do well if they were treated conservatively, whereas patients who had normal EGJ opening on flip often did have a symptomatic response and improve with conservative treatment alone. We treated these patients like achalasia when they had conclusive evidence of EGJ outflow obstruction, and they often did very well. Good symptomatic outcomes. Very few patients with normal EGJ opening on flip got treated like achalasia, and when they did, they generally didn't do well, and I think that kind of makes sense. But there also is this middle ground, patients that can have this equivocal manometry and still have this inconclusive flip. And there was a very mixed bag there on those patients, and I think that's a tricky bunch as to how to approach them. All right. Mentioned we were talking about flip and EOE. I know this is going to come up in a potpourri section later on, so I'm not going to go into it too much, but really appealing mechanism here. When we think about flip panometry, panometry came up as this idea of we can measure EJ opening, we can measure contractile response and motility, we also can measure the sensibility of the esophageal body. So really that whole aspect comes into EOE. And when we look at those factors, we can assess risk for food impaction. You get great objective measures at the bottom of the esophagus, also the top of the esophagus, an area that's difficult to see endoscopically, but that can help direct when to do endoscopic dilation, how to do endoscopic dilation, and also can be very useful to help monitor treatment response and disease progression. And recently we described a kind of a phenotyping pattern, so a lot of kind of details in here, but we broke this down looking at whether or not there was involvement of the esophageal body. That was the first cut here. If the body was involved, there was reduced distensibility or reduced compliance of the esophageal body. This seemed to indicate a more severe phenotype of EOE. They had longer duration of disease, indicating more time for fibrostenotic change. They had more likely to have strictures, more likely to have higher ring scores on the EREF score, and also they are much less likely to respond histologically to PPIs. Whereas on the other end of that spectrum, when there wasn't body involvement, maybe there was just EGJ focal involvement there, those patients very likely were going to respond to PPIs. So I think this has an evolving role here that'll help us even use this and maybe be even more selective in how we treat EOE going forward. All right, talked about flip for assessment of treatment response in achalasia. Number of studies now. This was really one of the initial uses for flip, and studies here that go back to 2012, 2013, using the 8-centimeter flip back then, but showed that poor treatment response in achalasia was related to reduced EGJ opening, reduced EGJ distensibility, and a number of studies have now looked at this and have shown that if you look at this, that EGJ-DI actually has a better correlation with symptomatic outcomes and radiographic outcomes in achalasia than using either basal LES pressure or the IRPN manometry. So I think this is a scenario where flip has become our first-line test in looking at patients who are coming back with symptoms after achalasia treatment, that usually in addition to time-bearing esophagram. All right, and I think with that is the kind of done talking about why one or the other. I think maybe I lend more on the side of why to use flip. But I think if nothing else, recognize that doing one of these tests is going to be useful in patients who are presenting with dysphagia. Really nice study led by Eric Shaw here, and looking at a cost-effective model to look at this. And they compared using either flip or manometry to a non-algorithmic usual care with barium esophagram, empiric dilation, and ongoing OTC PPI. And they could show that, looking at this, and all of these cost-effective models have a lot of different assumptions and a lot of different factors that are put in here. But they show that with both manometry and with flip, reduce cost to insurers, and then even reduce cost to patients as well, kind of based on impairment of quality of living and impairment of work productivity and things like that. I think one thing that was maybe a bit of a limitation of this analysis here was this idea that every patient with an abnormal flip had to go get a manometry, and so that was built into the cost here. I think as this continues to evolve, we'll find that that's not going to actually be the case, and so maybe this will even have a slightly better cost improvement for the flip algorithm of this. But if nothing else, doing motility testing for dysphagia is beneficial, even from a cost standpoint. All right, so just to summarize then, who gets what and why, and really kind of basing this on your local availability, your experience, patient preference, clinical scenario, bringing all these factors together to deciding if you're going to start with flip or start with manometry, also recognizing that that may not be the end of the road. And sometimes these tests do need to be complemented and using other pieces as well. Time-bearing esophagram, esophageal pH testing also can be very, very useful complements to putting together a clinical diagnosis. And as I mentioned, you got to do the tests here. There's me doing an awake flip on the top, me doing a manometry in the middle, and on the far right there, I'm doing manometry and flip at the same time. Yeah, looked pretty cool, but anyway, thumbs up. All right, thanks everybody.
All right. Ann's going to get the slides up for our next speaker. A couple of reminders. One, everyone who registered for the meeting got an email and can probably get it forwarded back to you from somebody else that has the link with all the speaker slides in it. So as some of this stuff is blurring by and you're trying to take notes, most of that should be already linked to you. All right, we'll get in now to a little bit more of the procedural aspects of this, and then we're gonna have all those speakers up to panel and do some case discussions, and that'll be an opportunity to throw some quick questions at them from the talks if you have those. And certainly there'll be a lot of back and forth with everyone during the panel discussion. So anyway, Zach Callahan is a surgeon at UT Nashville, and he's gonna get into all the good stuff that I like.
Thank you so much. Dusty's one of my favorite speakers to watch. It's a lot less fun to speak after him, but I'll do my best here. So I'm going to talk about procedural flip, so basically using EndoFlip for your myotomy. And it's a tough topic. It's a pretty broad topic, and I'm going to kind of let the data guide the discussion. So most of what I'll talk about today is esophageal poem, but also touch base on Heller as well as G and Z poem. So EndoFlip for E poem. So really, my goal is to help those people that are incorporating EndoFlip into their myotomies come up with some data-driven, concrete numbers to shoot for. So what distensibility index do I have to achieve so that my patient doesn't have dysphagia? Now, remember that historically speaking, the length of myotomy was limited by surgical exposure, right? So how far proximally could we dissect on the esophagus? How far could we see and reach? And then with the invention of POEM, that limitation evaporated. So now people could do a myotomy from the cricopharyngeus down to the pylorus, and it really wouldn't matter. And I'll tell you that early adopters of POEM took full advantage of this, often doing extended length myotomies, full thickness myotomies, but we learned pretty quickly that too much of a good thing is a bad thing. This is a review that we did looking at symptomatic GERD after POEM, and in the larger sample size studies, you can see the rate is somewhere between 16 and 22%. And these numbers by themselves aren't particularly alarming, but things get a lot more alarming when you look at studies that actually had pH testing, and these numbers are a little scary, as high as 80%. And when you think about the pathogenesis of achalasia, this makes sense. This is neural disruption of the esophagus, so it's not surprising that these patients are at high risk of silent GERD, silent esophagitis, silent progression to cancer. So this is kind of what I call the Goldilocks problem. So how do we do a sufficient myotomy to resolve someone's dysphagia, but not open it so much so that they have GERD? I think EndoFlip is a solution to this problem. And before I get into it too much, recognize that EndoFlip is an imperfect solution. And a big part of that is that the data on EndoFlip, at least for myotomy, is pretty varied. So there's 2 different catheter types. There's 5 balloon fills. We do myotomies for multiple different pathologies, all with different prognosis. And even within the same pathology, certainly doing a POEM on someone that just was diagnosed with achalasia a few months ago versus someone that's had it for 30 years and their esophagus is shaped like a sideways football, they're going to have a different prognosis. There's a few variables to report, and then there's all these different patient factors that can heavily affect the numbers. And the good news is there's a lot of smart people thinking about this. So this was a consensus in 2020 where people got together and tried to come up with one protocol for people to use, recommending a 325 catheter, 40 milliliter fill, and taking the pressure reading when it's at its highest. And this is a huge step in the right direction, but a lot remains to be seen. I mean, are people going to actually adopt this and all do the same thing? Then also, as we learn more about EndoFlip, is this even going to be the recommendation still in 5-10 years? So with that big grain of salt kind of stuck in all of our esophagus, let's get into the data a little bit. So this is the earliest study that actually used EndoFlip to, as well as Eckhart scores and GERD testing. This is out of Northwestern, 36 patients here. And what they found was that all patients had a final DI of at least 3. They saw their median Eckhart score drop from 7 to 0.7, not surprisingly. And I think they did something really smart here, which was they defined what was an optimal symptom outcome. So essentially patients with an Eckhart less than 1, which means their dysphagia got better, but then also with a GERD-Q less than 7, meaning they don't have bad reflux. And they found that 88% of their patients had a final DI between 4.5 and 8.5. So again, this is a big deal and a huge step in the right direction, but small sample size. And also I just pointed out that symptomatic GERD probably isn't the metric we should be aiming. And then lastly, this is a really wide range. It's hard to imagine someone achieving a DI of 4.5, then continuing to do a myotomy maybe into the pericardium to get up to 6 or 7. So this was 3 years later. This was out of Hopkins. This was also a big deal because in this study, they actually had post-POEM objective data. So they also saw their Eckhart scores grow from 7 to 1, but they actually got manometry afterwards. And they saw their IRPs go from 30 down to 13. And then when we get into the EndoFlip data, things get pretty interesting. So they split their cohort into responders and non-responders using an Eckhart of 3 as the cutoff. What they found was a very, very small but statistically significant difference in D-min as well as CSA. And interestingly, there was no difference between the groups in DI, and this was only at the 30 milliliter fill. When you looked at the 40 milliliter fill, there's actually no difference in any of these metrics. They do some statistics to kind of identify a CSA of greater than 80 to predict a good response. They also looked at reflux. So they had enough patients that had endoscopies to evaluate for esophagitis and pH testing. And yet again, we see this very, very small but statistically significant difference in D-min and a very, very small but statistically significant difference in CSA. And right away, you kind of notice a problem, which is that we just learned that a CSA greater than 80 is going to resolve dysphagia, but if you go too far above this, these patients tend to have esophagitis or pathologic reflux. This was our group out of Chicago. We had 77 myotomy patients, 71 of them underwent POEM. We looked at all of our EndoFlip data, trying to predict treatment response. So we also used a cutoff of Eckhart of 3 to indicate treatment failure. And this is kind of the major finding, which is that patients with a final DI less than 3.1 or a change less than 3 were more likely to have an Eckhart greater than 3. So I'll flip that and violate only a few literary principles here, but essentially a DI greater than 3.1 or a change greater than 3 predicts treatment success. And then we looked at GERD as well. We used something called an RSI, Reflux Symptom Index. This is more sensitive towards like atypical GERD. And we saw that a CSA greater than 96, these patients were more likely to have reflux at the 1 and 2 year marker, which indicates that obviously the goal CSA would be less than these numbers. Same group, now enough patients had gotten scopes at 1 year follow-up, and they were trying to figure out, can EndoFlip predict who's going to have esophagitis? And this was the major finding there, which was a DI greater than 2.7 or a CSA greater than 83. These patients were more likely to have esophagitis. And yet again, we run into a little trouble here because we just learned that a DI greater than 3 is needed to resolve dysphagia, and certainly these patients are at risk of getting esophagitis. And this was looking at GERD HRQL, and this basically just shows you that silent esophagitis is a big problem in this patient population, as there's really no correlation between GERD symptomatic scoring and esophagitis in this group. This was a much bigger sample size. This was out of the UK. Obviously, this is a huge table, but just zoom in on here for me. So achalasia, looking at Eckhart score greater than or less than 3 to indicate treatment response, and they saw a median DI of 4 with a change of about 3. And these numbers seem to be consistent. Unfortunately, none of them were statistically significantly different between the good and bad responders. And then I tried to stay out of the abstracts, but I thought this was a really interesting swing of the pendulum. So this group found clinical success in 90 and 93% of patients. And interestingly, their change in DI was much smaller, about 1.3, and it's kind of hard to reconcile these very different numbers from the other studies. So putting this all together, if we're looking to resolve dysphagia, we need a DI of somewhere in the 3 to 4 range and a CSA greater than 80, but if you overshoot these metrics too far, these patients are likely to get GERD. So these are kind of my 2 cents, just as someone that I guess thinks about this a lot. So I think DI is going to be the ideal metric. D-min and CSA are really just measures of distance and area, which is helpful. But if we're trying to sort out the nuance between persistent dysphagia and someone developing GERD, we're going to have to measure more than just a distance. We need to incorporate pressure into that. And I think that kind of begets the power of distensibility index. Along that same thinking, I think it just makes intuitive sense that change in number is going to be more important than final number. Everybody's esophagus is created differently, and I think that the ideal metric is not going to be a one-size-fit-all, but really a change, and maybe even just a % change. And then lastly, the numbers overlap a lot in these studies, and it can be a little bit discouraging, but it's important to remember that, and what I mean by that is, one study will say, well, you need this DI to resolve dysphagia, but the other study then identifies that cutoff for esophagitis, and it's important to realize that, just because they overlap, it doesn't mean that they're not both valid. It's possible that for some patients, in order to open the LES enough for them to eat, it's just enough that it's going to give them reflux. And it's kind of important to remind yourself and your patient, achalasia is an incurable disease. And although POEM is a treatment for it, it's an imperfect treatment. These are just my tips and tricks. So I like to put the EndoFlip catheter down first before putting my scope through. I find that the scope can kind of dilate up that LES a little bit, so I like to get my number at what its native value is. And then you have to wait at least 30 seconds, maybe up to a minute. It feels like an eternity, but you have to do it. And then check your balloon pressure. Someone else touched on this, but certainly you need a pressure. I like it to be in the 20s, but if that balloon pressure is low, these numbers won't be accurate. And then something else to think about when you're doing an esophageal poem, a CO2 leaks out into the abdomen pretty commonly. And certainly if by the end of the case that patient has a big capnoperitoneum and his belly feels like a drum, that's going to affect your numbers, so consider needle decompression. Do a careful endoscopy. I'm sure we've all been referred to a lot of achalasia patients that have esophageal cancer. Don't be that guy. And then I try and do a complete myotomy and then just repeat my endoflip once. Every time you pass the endoflip catheter down, one, it takes time, but also it's easier than you think to actually make a mucosotomy with that catheter, even when you're watching it endoscopically. So certainly be careful and then trying to minimize that trauma as possible. And then lastly, right after the balloon inflates, I feel like it really nicely compresses that submucosal tunnel. So I try and clip my mucosotomy right away. It's tempting to kind of look back in the tunnel, but then you kind of blow up that space again. So I feel like the endoflip very nicely presses things back together and clip close then. So that was really the bulk of what I'll talk about. I'll very quickly talk about Heller, G, and Z poem. And just fair warning that the sample size problem continues. So this was a cool study. This was out of the UK. So what they did was they reported on an institutional change. So basically, previously they had done a traditional Heller myotomy, going 8 centimeters on the esophagus, 3 centimeters on the stomach. And then at some point they decided they were going to use endoflip instead. So what they did was they centered the catheter on the area that was most narrow, and they did a myotomy over that way until the waste disappeared. And not surprisingly, these myotomies were much shorter, so 6 centimeters in the endoflip group compared to the 11 centimeters in the traditional. And what's cool is that the dysphagia rates dropped significantly and equivalently in both groups, kind of suggesting that maybe you don't need as long of a myotomy as we thought. This is simply just their values. And remember, there's no correlation here to outcomes. This is kind of just reporting, this is what we found. And it seems that post-myotomy, you're looking for a number between 5 and 8. And after fundo, somewhere in the 3 to 6 range. And this was a 40 milliliter fill. The 30 milliliters are listed there as well. This was a group out of Texas, again, just kind of reporting their experience, showing their median DIs before surgery, after myotomy, and after DOR. And these numbers seem, at least close enough to the other. And then lastly, this was the MCW group, I think probably pretty early on in their experience, just a sample size of 14. And they saw statistically significant differences before surgery, post-myotomy, and post-fundoplication. It always reminds me just to bring up the point that, when you're using endoflip in the OR, which Mike is going to talk about, you just have to be aware of if the abdomen is insufflated or not, because it makes a difference. So all these studies that have pre-insufflation values and then post-myotomy and post-fundoplication, if the abdomen is full of air during that procedure, that's going to affect these values. So if we're looking to resolve dysphagia with Heller myotomy, it seems that the DI should be somewhere in the 3 to 5 range, and then after fundoplication, maybe in the 2 to 3 range. And remember that none of these studies looked at GERD, so that's kind of remains a question mark. Real quickly, just to talk about GPOEM. So this is probably the biggest and best study out there. This was a multi-institutional trial. This was 37 patients, and they split the cohort, I should say. So most of these patients were diabetic gastroparesis. The second most common was idiopathic, and they split the group into clinical success and failure. They used a combination of gastric emptying studies as well as the GCSI to kind of separate patients into those groups. And they saw statistically significant differences of CSA and DI at the 40 and 50 milliliter fills. And then at 50 milliliters, their change in CSA and change in DI was statistically significantly different. They did logistic regression, and actually they were able to identify pylorus final CSA at 40 and 50 milliliter fill to be an independent risk factor of clinical success, which is great, but obviously that odds ratio is modest at best. And then this was a group out of Cleveland Clinic, obviously a very high volume center, unfortunately, not a super high sample size. 14 patients, significant difference in DMIN and DI, both pre and post GPOEM. These numbers are close to the prior study. Unfortunately, of the 14, only 5 patients got gastric emptying studies post-op, and 80% of them had improvement. And then this was Mike's group, sample size of 17, also with significant differences in DMIN and DI. And you can see these numbers jive pretty nicely. This group had 15 patients get post-gastric emptying studies with a 60% improvement. So putting this all together, for GPOEM, with the data we have, it seems we're shooting for a final DI maybe up in the 9 range with a change in the 2 to 3 range. But remember that only the multi-institutional trial actually identified a metric as predicting success, and only CSA was significant in that. So you kind of have to take that with a grain of salt as well. And then last and certainly least, this is ZPOEM. So this is a trial out of Michigan, 17 patients, only 10 of them actually underwent ZPOEM. They used something called an eating assessment tool to track dysphagia. And at 40 milliliter fill, the DI went from 2.4 up to 5.1. And then at 50, this was 2 up to 4, and the change was around 2. And this was a 40 and 50 milliliter fill. And then This was Mike's group, so sample size of 30 with EndoFlip, and this is kind of the data up there. I'll have you focus on the final DI being about 5.5 with a change of about 2, and this seems to be consistent with the other group. Now, granted, this is a different fill volume, and this group kind of tried to take the data to the next level. So they split their group into non-responders and clinical responders, and interestingly, change in DI was the only metric that was different between groups, and this makes sense, but then when you look a little closer, you realize, well, actually, the larger change in DI was the non-responder group. And I think the authors do a really nice job of explaining that, many of these patients that didn't respond had very large diverticulum, which makes sense of, one, why they would fail, but also why, you'd be doing a pretty extended myotomy to try and open that muscle up. So hard to take a lot away from these kind of 2 small trials, but this seems to be the numbers that we're shooting for. So putting the whole thing together, I think EndoFlip's a powerful tool, but the foregut is complex. I think many people in this room have gotten conflicting studies on their foregut patients. You get an esophagram and it says there's no hernia and there's no reflux and their motility is fine, and then you scope them and there's a hernia, and then you Bravo them and there's a positive pH, then you get manometry and they have IEM. So it doesn't surprise me that EndoFlip isn't some magic diagnosis wand that just makes everything clear. I just think it's probably another good tool to have in our toolbox. The data is small, but it's getting bigger. The data is flawed, but it's getting cleaner, and I think the only way forward is just to keep publishing and getting numbers out there. Thanks.
Get away from my squelch. All right, thanks, Zach. If Dusty and Abe and Zach, if you guys want to drag a chair up over here, we'll get the panelists up and get the cases ready. Afreen and Caitlin, you guys can kind of migrate up here. Are there any immediate questions? We got a couple minutes as we transition into the case presentations that you want to ask any of the speakers. They've already gone. We got a bunch. I'm going to start front and work back. Here we go.
Okay. Well, I have a question about a patient kind of case kind of thing where, I do manometry. I'm a nurse practitioner, and a patient had EGJ outflow obstruction on manometry. It was kind of mild. It was like the IRP was 18 and something like that, both supine and upright, had interbolus pressurization. But then they did a time barium swallow that was slightly abnormal, that there was a column of contrast at 1 and 3 minutes, but it occurred by 5 minutes. The tablet went down fine. And then they did EndoFlip, and the EndoFlip basically showed type 1 achalasia, even though they had great motility on manometry. And so when I saw the patient, I'd read or interpreted the manometry to begin with, but never saw the patient. And then I saw the patient afterwards, and they had home, they had symptoms, they had a Bravo, they then had door fundoplication, and they were still feeling terrible. And so I was re-looking at all these studies. I contacted the EndoFlip doctor, who is very experienced now, but it was one of his first probably 10 or 15 cases in Oklahoma City. So I don't know, maybe. But we're getting our own EndoFlip doctors, and how do we make sure everything comes together? How can it show really good motility and mild EGJ outflow obstruction, and then on EndoFlip show type 1 achalasia?
So manometry and flip measure different components of esophageal function, right? So abnormal secondary peristalsis can be seen on flip. They can have normal primary peristalsis. So I think a really important concept when looking at this. And yeah, I think even within that spectrum, type 1 achalasia is a manometry diagnosis. I don't exactly know what that means on flip. I could imply that maybe that's synapse and contractile response and some reduced EGJ to sensibility.
Yeah, I think he said it suggested type 1 achalasia.
Sure, yeah.
Off of the EndoFlip report.
I'm sure. Yeah, but I think, yeah, even within that, it's kind of coming back to looking at, I think we're starting point, and Zach summed this up so nicely about, and Abe as well, about the protocol. And, you got to look at that, kind of how was the study done? Did they do, a 70 ml fill volume? Did they really get that pressure up elevated to really kind of see how that was actually, I guess the confidence of the diagnosis, even within some of these classifications? And that's another kind of flaw in all these things that we do, is we put these thresholds, and, we looked at things, we try to make these best thresholds, but yet, a DI of 1.9 is not different from a DI of 2.1. There's nothing magic about crossing that 2.0. And so you kind of take all those pieces together, and yeah, I think with a, esophagram that clears and a manometry that otherwise was pretty mild, I mean, those are scenarios I think you sometimes even hedge on the treatment and doing LES Botox, or even trying to do something a little more conservative up front just to see kind of how things evolve over time can be time often is a really, really useful diagnostic tool. And yeah, and POEM is, sometimes you need to do that. But at least if you kind of have all those other pieces to put things together, I think that can give you a little more comfort in making that choice. And even people with slam dunk achalasia, it's not a 100% success rate doing a good POEM on there. So, sometimes things happen, but you at least try to have those pieces together to support the diagnosis. If you guys have any other.
Yeah, no, I mean, I think Dusty hit on all the points I was going to make. I think it's a great case because we think so hard about those patients. Even the last case I presented, we were still not comfortable. That was a patient where the flip was suggesting achalasia. The manometry was inconclusive. We were now pointing more towards achalasia. We talked to, the patient about Botox, pneumatic dilation, and not even going straight to myotomy, even in that case. And we ended up deciding on pneumatic because we were a little bit more confident, perhaps, than somebody who has normal peristalsis on manometry. And the patient did well for a year, and I'm assuming we're probably going to end up doing a myotomy at some point based on prior discussions. But I think with all the tools in our toolbox here, when it's not fitting together, we usually opt for more conservative treatments and see where it goes from there.
Yeah, I think that to some degree, yes, and to some degree, no, is the answer to that question. And the question, for anybody who can hear it, is, can FLIP differentiate between a mechanical obstruction at the EGJ versus LES dysfunction as being the cause of obstruction? And it comes back to even just how the esophagus responds to distension. And there is this thing that we see. This is the, Abe Slisks or my SLESCs. There is something to that. When you distend the LES, there's some people that want to contract. And so even within that, that's going to be a possibility. And we actually seem to see that a little more frequently in patients that have EGJ strictures. I mean, and we see that in EOE sometimes where there's an obvious stricture that's 13 millimeters. You put the scope through, it went through just fine, and you do the flip, and the max EGJ diameter is 8 millimeters. I mean, that's got to be some degree of LES contraction that's contributing to that measurement. So yes, there's going to be that time where it maybe is a little bit confusing. However, there's also a pattern on flip that you can see sometimes where it kind of is opening up, and as you're doing that sequential fill volume, it kind of reaches a plateau. And it's a pattern, some things is even more augmented if there is anterograde contractions, where the contraction will come down, you'll see the EGJ open, and it just kind of hits this plateau. And even as you're plotting out that EGJ diameter mark, it's kind of almost like flattens. I mean, that to me is a very typical mechanical obstruction type of pattern, but you don't see it all the time, and sometimes there can be that LES contraction that occurs in there as well. So sometimes. I don't know if you maybe I'll jump on the sedation one because I love that question. I get that question at every single flip talk I have ever given. And we have a paper that'll come out in CGH. It was accepted like last week, so I don't think it's EPUB'd yet. But we looked at this very specifically in response to these many questions. I'm kind of looking at conscious sedation versus non-fentanyl using propofol or ketamine or all the different agents. And at least if you look at the relationship to manometry, it doesn't matter. And, I think if you look at this, I mean, manometry done awake, flip done, always in sedated patients, conscious sedation, propofol, whatever, it's similar. You see these similar findings that are very much within line with even the degree of differences between secondary peristalsis and primary peristalsis like you would see. So I think it just comes down to the idea of, the acute fentanyl, acute use, there's very minimal motility changes that occur with that. And when we see this opioid-associated esophageal motility, that's much more of a remodeling that happens with chronic opioid use. I don't know if you want to tackle the
Yeah.
2.0.
Yeah, the 2.0, I mean, a lot of my videos, I was still showing the 2.0, not the 300. And you certainly with the 16 centimeter balloon there, you can still see the contractions going down. If you're talking about the 8 centimeter balloon, where a lot of the surgical data is from, there's not a lot of smooth muscle esophagus you're seeing there. I haven't used it too often, but you certainly can see some distal contractions sometimes. But from a purist standpoint, if you're really looking at motility and trying to get most of the smooth muscle esophagus to look for things like spastic reactive patterns, I think it's advisable to use the 16 centimeter balloon, either with the 2.0 or the 300 system.
Oh, and actually, if I could maybe just jump in, I think that even with like the rack rule of 6, yeah, I mean, that's like the definitive, the perfect, you got everything. I mean, if you lost track and you maybe saw 5 or 6, I mean, like that's normal, It's so, yeah, I think another one of these thresholds that's out there that, yeah, I mean, even if you have a couple antegrade contractions, but they're really distinct antegrade secondary peristalsis, I mean, the odds are that patient's going to end up having normal peristalsis.
Just super quick on the sedation thing. I'm sure this will get stated at some point, but inhaled anesthetic does affect panometry significantly. So, like, if your anesthesiologist, if they're not tolerating conscious sedation, they could intubate your patient. Obviously, just be aware that if they turn on the sevoflurane, which for many of them is just a reaction, like once the tube's in, they crank up. So that will affect your motility reading. So just be cognizant of that.
Yeah, thanks for that, Zach. Yeah, when I was talking about sedation difference, we were looking at endoscopic sedation, and we were really focused on that fentanyl because that's what people often think about in that context of opioid impact. And yeah, and that doesn't seem to affect how manometry affects, or at least relates to the flip.
All right, I think we'll move
All
into
right.
cases.
We're just going to move on to cases, but we will have time at the end for more questions. So please save your questions. We've heard all about flip and how to use it. So we're going to switch gears a little and talk about how do we apply flip to cases. Our first presenter is my good friend and colleague, Fareen Kamal from Stanford. So she's going to be presenting our first case.
All right, thank you guys for inviting me. So the goal for this next half hour, because I'm going to split it, is to be fun and also to be simplistic. Because when I first started learning flip, if I got a bunch of data, it honestly just goes over my head. So my goal for the first session is to be kind of simple and just talk about two real case scenarios where I felt like flip was helpful in my evaluation. Now, what I'm going to do is, because I'm a gastroenterologist and I face a lot of dysphagia, I'm going to ask the panelists a lot of questions, mostly just to gauge how you guys think these through, because sometimes there can be variations in how we do things, which is honestly fun. Okay, so the theme for the first case is EGJ outflow versus a cricopharyngeal bar, which I feel like happens to me quite often. So I had a patient who came into my clinic. She's 69 years old, has background history, breast cancer, high blood pressure, but essentially was coming in for symptoms of dysphagia, no weight loss, occasional regurgitation. So really, it was just mostly for dysphagia. Now, eliciting more symptoms, she has been having some vomiting, some reflux symptoms, especially when she eats. It's been going on for the past few years. Initially, it was mostly liquids. If I swallowed a pill, it would get stuck. Now it's actually solid food dysphagia. When I asked her, is there specific foods that cause your symptoms to get worse, she really couldn't figure that out. Now, this was prior to her seeing me. So, we get these outside hospital records, and this is the record I have. So I have a barium esophagram that showed a large cricopharyngeal bar. In general, the peristalsis was noted to be moderately impaired, but nonetheless, contrast passes easily into the stomach. Now, to the panelists, if you see this report, you always have to think of a differential diagnosis. What would stick out to you?
I guess the first thing I would have thought about is in the clinical history, about where the dysphagia was localized.
Oh, she points to right here.
To her chest? All right, yeah, then this is probably a clinically insignificant cricopharyngeal bar. I also, almost always, I want to see my own images. I mean, I feel like barium radiology has kind of become a lost art, and some of these subjective reports are just a little bit, especially with the motility assessment of esophageal dysmotility, mild, moderate, often not all that helpful.
I don't think I've ever seen the word large cricopharyngeal bar on a report before.
Yeah, I'm not quite sure what that means either.
I mean, I see Zenkers a lot.
Yeah,
but-
prominent, you know, with some degree of narrowing. Yeah, I think I would just want to see what this image actually looks like.
Now let me ask you, what's your confidence level? If somebody points to here and they say this is where food is getting stuck, how confident do you feel that that's in your proximal esophagus?
50-50.
50-50, okay.
I think it's below the sternum. At least it's in the esophagus. You know, if they talk to their throat, I mean, you're a little more thinking that it could be something more oral pharyngeal, but certainly we see the referral proximal from esophageal dysphagia. But once they're pointing to below the sternum, it's not going to be an oral pharyngeal issue. I mean, that's going to be esophageal. Yeah, whether it's proximal esophageal, distal esophagus, I mean, not the way the esophagus is wired to help be that precise on localizing the area of obstruction.
What about for the rest of the group? When somebody points to kind of this top portion of their chest, how confident do you feel?
Yeah, no,
that
I think
in
it's
the
helpful
proximal?
because like Dusty said, you're thinking esophagus. I mean, where we are, we have separate, you know, evaluations. We have our modified barium swallow, video fluoroscopic swallow study, which ENT oversees that at our swallow center. Then we have our radiologist doing, you know, either if we want a time barium esophagram with tablet or, you know, a standard esophagram protocol where they're doing the water siphon maneuver to look for reflux, whether or not that's helpful, you know, we can, you know, certainly talk about. But, you know, because we separate that out, I think that becomes helpful, especially if it, you know, I'm not really concerned with any other symptoms of coughing when food is stuck and other things like that, that it is oropharyngeal, that I'm really going to go down my esophageal dysphagia pathway a little bit more.
Okay, great. So prior to the patient seeing me in clinic, they did undergo an esophageal manometry. The top one is the multiple rapid swallow, and then I have representation of 2 swallows on the bottom and the right-hand side. How would you guys, I know you don't have any numbers, the IRP came back at 30.6. In the report, it talks about 30% intrabolus pressurization, and overall about 70% of the swallows were overall normal.
Well, I'll take the position of someone who doesn't read manometry,
Yeah.
but just sort of infers a few important things. And I generally, we're typically just trying to sort out, you know, is this someone who's going to need a myotomy, or is this someone who's going to need something else? And this is in the something else category, most likely. This is someone who's got intact peristalsis, whether it's hypercontractile and what the DCI is, whatever. It's peristalsing. It's opening the LES. So this is someone who I'm not going in looking for achalasia. I'm not doing LES procedures most likely on this person. I'm probably going to begin thinking about reflux or other things, depending on the symptoms.
And Jacob, what happens if I told you that the IRP came back at 30.6?
Yeah, then I'm just going to assume that they're maybe centrally obese, maybe they've got a sliding hiatal hernia, but that's almost everybody that gets sent to me is something like that. They're EGA outflow, but they're definitely not obstructed, you know. So my general sense is that those tend to be sliding hiatal hernias, if not a stricture or something, but usually a hiatal hernia for me.
And to the panelists, and especially so the group can be aware, because EGJ outflow, we had a lot of talks about it at AFS, which is wonderful. Do you might talk about how do you work through? So you get a manometry, it's concerning for possible EGJ outflow obstruction. Do you mind just talking to us a little bit about how you would approach this yourself if you saw this patient?
Oh, I mean, this is why we do endoscopy before manometry. I mean,
Well, this came before. So you,
Oh, yeah, but I
you're
think that-
seeing a patient in clinic, and this is all you get.
yeah. Well, you arrange for the endoscopy at this point. I mean, this is very much a stricture pattern. I mean, you see the sliding hiatal hernia, kind of best in the top image there. It's, I mean, good liquid bolus clearance, so not too concerned about the, motility aspect of this IRP. And yeah, like Jacob said, I mean, this is, normal peristalsis, even though it's maybe a little hypertensive. It's a nice propagating peristaltic wave. It's not in that repetitive jackhammer type of pattern. I mean, this is what the esophagus would do if there's a mechanical obstruction there. And I think, yeah, if endoscopy probably shows a small hiatal hernia, maybe with a stricture, and a dilation has you on the right track. And yeah, it's almost unfortunate that somebody got their nose violated to do this study at this point of the evaluation.
Abe, do you have any other thoughts?
Yeah, I mean, I think I would go down that road as well. I mean, certainly would like to see images of esophagus, perhaps, depending on when I'm going to do the endoscopy. I might get a time barium with tablet before that as well. And then, on the endoscopy, it's one of those cases where if you see a stricture at the bottom, you're going to deal with it. If you don't, maybe you do a flip, with that endoscopy as well. And then you'll have to decide on what to do if it ends up not being, a stricture. But I think already going into it, I'm not thinking, similar to what Jacob said with his sort of how intuitive he is on these cases, I'm not thinking it's going to be a very aggressive management right away. Regardless, it may eventually get to something like that. If you're diagnosing this patient as outflow obstruction with spastic features, there are patients that eventually, sort of declare themselves as going down the spastic achalasia pathway, but this doesn't seem like it's going to be one of those cases based on the appearance and what we know so far.
And do you guys all, for your manometry protocol, do an upright swallow? And if no, can you tell me why? And if yes, can you tell me why also?
Yeah, Jake, what's your manometry program?
Yeah, so I'm in like a manometry desert, so it's a lot of like Chicago class 3 and not a lot of positional and not a lot of rapid, so it's an interesting situation.
So we do the Chicago classification protocol. Shocker, right? But we really, I mean, I think where that change of position really comes into play is, the manometry catheters are susceptible to angulation artifact, and sometimes if there's a little hernia, sometimes even just anatomically, it's just that little bend that can cause pretty significant elevation in IRP. And even kind of when we started looking at this upright swallow, I mean, it was about a sixth, 1 out of 6 patients just normalized. And that group of patients that happened to, I mean, never had abnormal barium swallows, like didn't really have dysphagia that often. I mean, just that simple maneuver of sitting someone up and doing a few extra swallows can kind of help get you out of, that confusing situation. And so, yeah, that's why we do it. And then our protocol also includes some multiple rapid swallows, but we don't put a ton of stock in that, to be honest. But then we end them all with a 200 cc rapid drink challenge, which especially for EG outflow obstruction, I find very helpful. Seeing if even with that type of stimuli, if you can see LAS relaxation, and maybe even more so if you see like actual pressurization during that rapid drink challenge. I mean, that's really helped support or at least the presence of an actual outflow obstruction.
Yeah, we do the same. And, outside of the upright swallows helping exclude outflow obstruction, in these inconclusive achalasia patterns, sometimes you'll see the upright IRPs even higher than the supine IRP. And that actually helps, point you in that direction of achalasia. And then, like Dusty was saying with the rapid drink, whether it's post-treatment achalasia or confusing cases, really, really helpful to see pressurization there if you're deciding on retreating the LES.
Wonderful. And the last question I have that's actually for the surgeons that are in the panelists. I don't know if you guys manage cricopharyngeal bars with a myotomy, but my question is that, and actually I'm curious, is how often do you look at the manometry to look for pressurization in the proximal or at the UES? Or is that unreliable? Is it reliable? Is it data that you use, data that you may not use? Especially in this
don't.
patient who has a large cricopharyngeal bar.
Yeah,
I don't know data.
I don't know data either, but if I have manometry on them, I would look at it. Not sure I know hugely what to do with it. And I know that intervening on just bars that don't have diverticulum is not great. It's a very high complication risk if you try and do myotomy in someone without a tick, so yeah.
Yeah, I am seeing more of these, and I don't exactly know what to do with all of them. Oh, Mike does.
Well, yeah, I actually think it's very important that people understand that you have to be very careful. I think manometry and flip are very not dependable for the fractal fringes, and we get kind of numbers all over the place. I would never permanently open someone's fractal fringes unless they're absolutely sure. Like if they have a diverticulum, that's fine, but if there's no diverticulum, it's just a thick bar or whatever they say. If you open that permanently, you're putting that patient at risk for aspiration for life.
I've Botoxed a couple of them for that reason.
I think in a very rare circumstance, there may be some benefit, but it's rare. Most of these patients, you do not want to touch it. If you're going to do anything, Botox it first. And I have a few cases where I Botoxed people and they've aspirated for 6 months, and then it went away. And thank God I didn't open it permanently. So be very careful opening up the fractal fringes, all I would say.
Yeah, and I think just a great point that Mike. Yeah, I hadn't even thought about like the UES pressures here as being part of this case. But when we think about like the reactivity of the LES in response to distension, I mean the UES is a much more reactive sphincter to a point where with flip, when you distend the UES, I mean it's going to contract. I mean I think there is a few things about flip at the UES, and I say we don't use that, and I don't know if that's going to be a key use for it, looking at the relevance of CP bars. I mean, there'd have to be some level of paralytic done to try to look at the mechanical effects or something like that, because, very, very reactive organ.
Joe Richter just dilated with a 20 millimeter sangre.
Yeah, no, that's what I think, that's what we typically do with people who we really are confident it's a symptomatic cricopharyngeal bar, and using a large caliber bougie dilator, always caution patients, or at least guide them that there's a chance that this is going to come back and you may need another one. But symptomatic response is actually pretty good.
Right, patient needed it twice. Had a lot of pain after the dilation.
All right, wonderful. I just wanted to spark a discussion on
I'm
that.
nervous
All
about
right.
where Freen's leading me.
But moving on, so this is the endoscopy. So I bring the patient for an endoscopy. What are your thoughts? So we threw out stricture, we threw out hiatal hernias.
Nothing too exciting. I'm not going to AFS grade that valve for you, but I wouldn't be shocked if this is someone who had a little slider or had a positive pH. But nothing immediately actionable without more information.
Yeah, I think the bottom left there looks like maybe a little axial displacement coming in, but certainly at least those still images of the LES look kind of like that achalasia type of hypertonic sphincter, but even that, you kind of worry about the reactivity of the distension there, even with air, and the setting of a hiatal hernia can be deceiving sometimes. At least no obvious dilatation or fluid sitting in the esophagus.
Okay, great. So I did endoflip, and these are static images. But do you guys mind walking through the numbers that you see and things that might be concerning for you? How would you interpret this yourself?
Yeah, so, going by the analysis we're going through earlier, so if you look at your 60 milliliter volume, median DI, I'm assuming, is calculated there. The pressure is adequate, so it is below 2. And then your max diameter, I'm assuming that 9.4 is over the whole study. So you're ending up with this Rio classification. Now, like Dusty said earlier, your endoscopy and how you're doing, it's going to matter for this patient as well. Did you feel a pop through the LES? Did you not? But ultimately, this is coming out as with a weak contractile pattern, Rio with that weak contractile response. Consider achalasia, right? There's not a lot going on, at least on these images we see above the LES, but there is some pressure, peaks going up a little bit, and diameter narrowings going up a little bit. So what I'm going to do here will depend on what, I've talked to the patient about going in. Am I just going to be dilating? Am I going to be considering Botox? Have I thought about doing pH testing beforehand to make sure, that if I do intervene here, even conservatively, it's not going to be something that's going to make their symptoms worse, which goes back to our initial discussion on the patient. I ideally wouldn't go in here without doing other testing unless, I was just doing this diagnostically first, perhaps with a small dilation.
Now that says you've got absent on all of those, right? And so the spikes that we're seeing, is this during fill, presumably?
Yeah, those are still absent contractile.
Yeah,
Yeah.
so I look at the 2/3 of the, or as much as I have, and so that's how I have absent, based on I didn't see.
Anything coming down? Yeah. Well, yeah, I think this a little bit, when you get, if you have separate people doing these things, right, and you get a report like this with a low DI and a low diameter and absent contractility, someone who just does the flip, who hasn't seen or thought about the patient, or maybe they have, but they just did the flip, and then they put it in provation, it'll come out, it'll force you into these like very narrow categories, one of which will say suggest type 1 achalasia. So I've frequently, from a former gastroenterologist at our institution, had a lot of these patients who have reports in the chart, and the resident will come present them to me, and they'll say, this is a patient who's here with type 1 achalasia. And we have to kind of like, you've got to really like, where'd you get that information from? Because that's what this will tell you. But you knew going in that this is someone, one, you had manometry that showed you they have primary motility at least. Two, their symptom, well, we haven't seen, I don't know, well, I guess we didn't see the barium, but it didn't sound like it was an obstructed barium. They emptied. So I definitely would lean away from assuming that this was achalasia, no matter what that flip report said. So to Dusty's point, like, and Abe, you scoped them. Was it a pressurized valve? Did you interrogate it a little bit in retroflex? And at the end of all of that, if you really were dealing with dysphagia as a primary problem, and you got that on flip, and maybe you thought there was some resistance, maybe Botox them at most as a trial or dilate, but I would be very suspicious of that over-representing an obstruction in that patient.
And to give you some information, so when I do on my endoscopy, when I take pictures of the EGJ, I do it before I intubate because that can kind of open it up. So I did find on the bottom right picture kind of represents best. I did experience moderate resistance as I intubated into the gastric lumen. All right, so before I say what did I do, Jacob said Botox, I think. What would the other group do?
I would get another esophagram. I'd get a time barium esophagram to help kind of clear things up a little bit, especially if I can't see the images on the first one.
Yeah, absolutely. I think during the endoscopy, I would have done a dilation, probably, sequential 18 to 20 balloon or until there was a stricture disruption. And then, if there were persistent symptoms after that, I would do a time barium esophagram with the tablets, and I would have them do a cervical phase in that as well, just to see what a large cricopharyngeal bar is.
But Dusty, let me ask you a question. Would you still dilate if you didn't see a stricture?
Yeah, based on that flip and this whole story, I think I'm still going into that endoscopy with a pretty high pretest probability that there's a stricture there. And I think that's one thing with that flip. And I would have called that flip probably more like a high pressure impaired disordered contractile response. There was some activity, that weird contraction in the middle, kind of pulling the esophagus up. That's a reactive pattern to me. And so when I see that in endoscopy, and I, kind of otherwise having a lower suspicion for achalasia, one of the things on that differential for spastic reactive flip is stricture. And you're there, it's an opportunity. Doing, observed guided balloon dilation is very, very safe and can be very effective. And I've certainly had cases where you don't see the obvious stricture, but after you dilate, you see the disruption. It kind of pulls the stricture out. So yeah, I think that's one of those things with, it's flip and endoscopy and flip, and letting the two kind of guide each other.
Yeah, I would do similarly. I would have liked to get the time barium before this, and then if I really am convinced the symptoms and the time barium are really pushing towards the problem is getting things through the LES, I would start with the dilation after that flip. If there is no disruption of any fibrotic, area, and I go up to 20 and nothing really happens, I'm probably planning Botox on that same endoscopy. But if I didn't have any information besides this, I'm probably just doing the dilation and then reassessing afterwards.
Great. Well, this is what I did. I Botoxed because my suspicion was just with the manometry and the hypertonic LES, I went ahead and Botox. And the patient did respond, but it was a short duration. It was a few months. They actually underwent a repeat Botox injection from one of my colleagues, also got some response, but it only lasted for a short period of time. So then a year passes, and I get a repeat barium esophagram. And then this time it shows, again, the cricopharyngeal bar. But as I highlighted it in yellow, now more recently, there's this narrowing at the level of the EGJ junction. What are your thoughts?
Yeah, now anytime if I had done Botox and months go on, I think, we sort of make up this thing of 6 months, because sometimes if you actually look at the achalasia data, Botox can sometimes last much longer than that, 9 to 12 months in some patients. But it's the opportunity to retest, and oftentimes in these confusing patients, I will want all our tests, time barium with tablet, repeat manometry, and potentially at that point, depending on how confident I was, maybe again we're going to flip before deciding on an intervention. Now, I'm not going to do Botox a third time at that point. So you're really down to, if you're convinced that this LES is the problem at that point, you might think about offering a 30 millimeter pneumatic dilation, at that point. But I still, just with this esophagram, it's not going to be enough for me to decide just yet. I think the patients who have these sliding hernias and they might have outflow obstruction or even an achalasia physiology underlying it, they're very, very, very challenging patients that we're often getting as much data as possible to understand what to do definitively.
So I feel strongly about these because, again, the type of referral pattern that some of you will have and that I have, and if you're seeing and using EndoFlip, if they empty, now I'm with these guys, I always get it timed before I see the patient, so that's consistent now. That took a while, but that's important. But if it empties the barium into the stomach and they are not overtly, I eat, I regurgitate, I eat, I regurgitate, if it's anything that isn't just strictly speaking really clearly achalasia and they empty on the barium, I am super skeptical of anybody that's pushing me towards myotomizing that person. And I don't know for sure what it's going to be, and I may wind up just like shrugging at you at the end of all of this. But this is someone who you've got to have manometry to me to support achalasia in someone whose barium empties, whose symptoms are not really classic. Like that's where I'll flip and intervene without manometry a lot, because we're also in a manometry desert. So I'm very comfortable with that. I think, like, unfortunately, like somewhere 30-odd% of my poems are without manometry. But this is the one where, like, I do draw the line, and I don't feel good about that.
So I have a question, because in our practice, we do barium tablet swallow every GI meeting. And the utility of that is uncertainty. So here in the case, the liquid's obviously passing easier into the stomach, but the tablet doesn't pass despite multiple swallows. So what's the significance of that to you from your perspective?
Yeah, I think it's another data point. And yeah, Joel Richter had a nice study a few years back looking at time barium esophagram with a barium tablet and showed that does increase the yield a little bit. But it's kind of looking at this, this sounds a little bit more like a mechanical obstruction if there's just tablet passage, but you get normal liquid passage. But yet, at the same time, people with spastic achalasia can have this, or they'll have liquid clearance and then the tablet will get hung up. So I just look at this as abnormal, but it's not telling me necessarily like this isn't achalasia, this is achalasia. But I think it does support that there's a bit of an obstruction there. The other thing too that I think is maybe worth noting on that tablet is that here it's kind of important that it says tablet did not pass despite multiple swallows. Every so often you'll see these tablet, the tablet was hung up briefly. I don't make any sense in that. Everybody's tablet gets hung up briefly, so it's got to be like stuck and it didn't pass. Yeah, Mike.
I guess I would like to know why you did Botox. You did Botox, you got a great response. Why are you not now permanently opening their EGJ? I hear what you guys are saying, but you did everything. The only other thing I would maybe say is improving manometry, because I think you said that manometry came to you, you didn't do it yourself. So that's the only thing I would say. We haven't repeated manometry in this patient. But you have a lot of things pointing towards outflow obstruction here. And you have Botox that proved that if you
Yeah, exactly. So that's actually, so the manometry was done at Stanford by a colleague, so I trusted the colleague, so that's why I didn't need to repeat it. But that's why I wanted to bring up this, because I actually referred the patient for consideration of POEM, but I wanted to have this discussion because I feel like sometimes POEM for EGJ outflow, sometimes it's not as black and white of a discussion as, say, achalasia. And so there's so many variations, and some people feel strongly, go straight to POEM, the patient is symptomatic. And that's how I felt. After the Botox, ×2, she's still having dysphagia. I proved that the Botox worked. But some people would be very hesitant, and they would say, POEM maybe is too aggressive. And so that's why I wanted to bring this up to see what people would talk about.
I was gonna say that once we have the therapeutic trial with Botox, it's probably, another way to support that the patient can go for a full procedure. And I was gonna ask, in the past, we used to do additional imaging with EUS or CT scans of the G junction in the setting of EGJ outflow obstruction. At what point do you decide to do an extra assessment of that area, possibly with EUS?
Yeah, for us, we usually, the yield on doing that in every EG alpha obstruction is frankly quite low. But typically when we're having someone come in with this and we're doing Botox, we'll do it with EUS actually. And, kind of get two birds in that scenario where you can rule out there being anything, extrinsic, or sometimes, we've had a few cases of, these intramural leiomyomas and kind of funky things. But you also have the opportunity to guide the Botox into the LES. So, we do it pretty commonly in this scenario, getting EUS to guide the Botox. Yeah, CT, not too often.
All right, wonderful, guys. We are going to now transition to more of a surgical
if I
direction.
could actually, but this is something I think that even if, say they did a time-bearing esophagram, that was like looking good, this is someone I probably would have offered a dilation to, pneumatic dilation. Because with POEM, was it an extended POEM?
They haven't done a POEM yet. I'm referring for consideration.
Okay. Yeah, because I think if you're going to do a POEM here, this would be a scenario to do a very short, tailored POEM to the LES. Because this is definitely one of those scenarios where if you're cutting half of that peristalsis, you're cutting normal peristalsis, and you're going to run the risk of having a blown-out myotomy in that scenario. And so this is actually the scenario where, when you're kind of still on the fence here, I like actually this is where ESOFlip can be a nice way to do a graded dilation, and even allowing you to check at 22, check at 25, even you kind of sequentially can go up to 30. And I don't know, there's just something about this story here that I'm not convinced this is the LES, and there is something mechanical potentially going on here. And yeah, I think doing a dilation starting to 20 and maybe easing your way up to a 30 millimeter dilation may help preserve some peristalsis, but yet also addressing some LES obstruction if everything else is kind of still continuing to lead toward that.
All right, wonderful. You guys did awesome, and thank you for answering all my questions. We're going to transition, I think, to more a surgical direction for the use of EndoFlip.
All right, so I'll introduce again Caitlin Houghton, who's a surgeon at USC, and she's going to keep peppering us with questions. And we've lost
All right, well, thank you so much. I am now bringing you to the operating room, and we've touched a little bit on what I'm going to talk about today. But really, how much do we trust our technology is going to be the underlying question. And I have two cases. I don't know if we'll get to the second one. But the first one is EndoFlip in a Heller myotomy. Case presentation, 34-year-old male presents with progressive dysphagia to solids and liquids since 2019. He had a 50-pound weight loss recently. He's a nurse at the hospital, and he has an Eckhart score of 10. Manometry shows 100% failed peristalsis, LES residual of 34.2, and achalasia type 2. There was pan pressurization on the images. He has a veg that shows delay in contrast passage into the stomach, mildly dilated esophagus, and it looked like this. We're not going to belabor the workup, but it was confirmed achalasia, and we go to the operating room. So, just a little bit of discussion about the surgical dogma for a myotomy. Heller myotomies You typically want 6 to 7 centimeters on the GE junction, 2 to 3 centimeters on the cardia, with a total myotomy length of 6 to 8 to 10 centimeters. And that's been really shown to be important in the surgical literature. We have Oschlager's paper from 2003 that showed the extended gastric portion of the myotomy is really important. You need 3 centimeters versus that typical 1.2 that they were doing prior to this study to get less frequent dysphagia postoperatively and have more success. And that the extension onto the cardia was actually more important in lowering the LES pressures than the esophageal myotomy portion. So that's surgical dogma. And then we go to POEM, and we think, okay, well, originally Inouye did 6 centimeters of G junction, 2 centimeters in the cardia, total myotomy about 8 centimeters, really mimicking the surgical data. But over time, they started to notice that if you're using EndoFlip, which most patients most people doing POEM are using EndoFlip, they're starting to shorten their myotomies in POEM. They're doing shorter myotomies, and they're doing 3 to 6 centimeters in some studies that are showing no difference in Eckhart scores and results afterwards. And they're having less pH positive reflux afterwards, shorter procedure times. Maybe we should consider in our surgical myotomies to do a little less of a myotomy and tailor it to EndoFlip. So maybe EndoFlip can help tailor the length of my myotomy. So I'm going to go in. I'm not asking you guys questions yet, but I am going to, setting this up. Okay, so I do the Heller myotomy. I bring EndoFlip into the room like I normally do. This is so I am already insufflated at this point. I'm insufflated and I'm in Trendelenburg positioning when I get this initial EndoFlip, because I'm thinking surgically, I don't want to disrupt my procedure so much by going flat. I'm also robotic, so I can't really move the table all that much. And so my initial D-min is 8.4 and DI is 1.08, confirming that I have an abnormal EndoFlip, which was not done prior to the OR. But this is my initial starting point, and what I'm looking for is a change in distensibility of at least 3. So I decide here, we're going to let this play a little bit. And then, so we've got at 40 milliliters, and so I start to do my myotomy, and here I'm clearing up the esophagus anteriorly. I'm mobilizing the vagus nerve to kind of creating the space for my myotomy, but I'm gonna tailor this to EndoFlip. So everything's ready for the myotomy, and at this point, I'm gonna put in the catheter again, and I'm now palpating the esophagus to see where is that point of constriction on the bottom, and can I tell by palpating, okay, this is below, this is above, and I'm planning on tailoring this to the myotomy, or to the EndoFlip. So I end up palpating, and I can see when I palpate, I don't know if you can see it very well, the pressure kind of goes up a little bit, but it's a little hard to see. And I measure out a length. Oh, what that was supposed to show is that there's hashtags on the EndoFlip, so I can tell that it's a 3 centimeter area of constriction, which is typical to an LES length. And I'm measuring out where I should do the myotomy based on the EndoFlip. So I'm going to do a 3 centimeter myotomy. That is my plan. We just said typical is 6 to 8, but I'm planning a 3 centimeter myotomy. I go through, I do the myotomy. So we're going to go down to the circular muscle fibers, and I'm going to continue this myotomy only to those blue dots. So my goal is to tailor and get these circular muscle fibers opened up just between those 2 dots. And you'll see in a second, we're going to go up to that blue dot, cutting the circular muscle fibers, and then we're going to go down to the to do the distal portion, looking like a pretty good myotomy mucosa there. Get really nicely getting those circular muscle fibers. I'm up to my blue dot. Maybe I'm cheating a little bit above it because I'm like, ooh, this is short. And then I go down, and you can see some sling fibers. You can see I'm cutting across some sling fibers, but I'm just on sling fibers now. My blue dot is right there. So this is likely not gonna go the 2 to 3 centimeters onto the cardia that we are told is essential in the robotic literature. So we're gonna do it there. I'm done. I measure. It ends up being about 4 centimeters once I move the muscle fibers off this myotomy. It ends up being closer to 4. And then I'm gonna show you that when I do my endoscopy, at this point, I just wanted to know where the G junction is, because I'm like, ooh, I didn't really go on the cardia. So my fellow is in firefly mode, showing me right where it is. My G junction, my Z line, is what I'm gauging there, is right at that green light. So I'm barely on the cardia. So my question to you now is this a complete myotomy? Would you be comfortable leaving the operating room, my surgeon friends, with a 4 centimeter myotomy with only 0.5 to 1 centimeter below the Z line?
Yeah, I mean, that's what the endo flip is gonna do, or is gonna help me with. But I'm with you. I mean, I'd be a little nervous, but I think flip gives you a lot of comfort, a lot of latitude when it comes to myotomy to know both when you've done enough and when you need to do more. So I do more poem than Heller by far, but I think that there are definitely times where I'll go in both of those directions. Like, you know, you're looking at something that looks like it probably needs a very short cut, and you do that short cut, and it's kind of a quick procedure, and the flip goes down, and it didn't really change like you thought it would. And that's when I kind of go back and reassess, well, maybe I did need another centimeter distally. But equal parts, you know, there are times where you're thinking, I've got to do the full thing, you know, for whatever reason, it looks very obstructive, or you're kind of in the tunnel and the muscle fibers are very thick and you're going through sling fibers, and you do more myotomy, and then you're confirmed to be happy with the endo flips. I think it kind of works on both ends. So I would not be uncomfortable if you had the flip and it blows your DI wide open and there's no area that appears constricted or constrained. I could live with it, yeah.
Okay.
Quick one. First of all, Caitlin's YouTube channel is excellent. You should check it out if you haven't. She has a lot of great videos up there. And then secondly, so a few logistical things with a robot. So robot is all bipolar or monopolar. There's no ultrasound. So during this, I imagine your endoflip was not in the esophagus.
Okay, yeah, so I actually unplug it. So it is in the esophagus. So I keep the catheter in, because I've had scenarios with me and my partners where we've done the myotomy and want to do an endoflip at the end, and the catheter went right through the myotomized portion, and we're like, ooh. So I actually keep the catheter in, but if you unplug it, you can still use your flip and then plug it back in to redistance.
After
so you get-
monopolar.
With the monopolar.
That's good to know. And then, let's see, my second thought was that, no, it's okay, I'll save it.
Yeah, okay, yep. All right, and then I was like, show of hands, surgeons, are you comfortable now, or do you want to see the endoflip before you make that decision? Probably want to see the
Nobody's
endoflip.
comfortable now.
All right, let's, okay, so is this adequate? Who wants to see the endoflip? We want to see the endoflip. Okay, there's my endoflip. I mean, the number's 7. So I might have over-myotomized, you know, it's like I've spread the muscle really far apart. I mean, this number's 7. It actually is in line with what the papers say would be adequate. And then after my fundoplication, it went down to about 4.8, 4.5. So that was the first case. Do we trust it? I trusted it empirically in this case. Yeah, go ahead.
I feel like in endoscopic myotomies, it makes a lot of sense to really try to dial in exactly how much you're cutting, because you don't have ready access to an anti-reflux procedure unless you do TIF, and that's a big instrument to put down there. You have a tunnel, and you just created. But I feel like you're here surgically, you're about to do an anti-reflux procedure. Why do we care so much here?
Yeah. And yeah, exactly. And with the anti-reflux procedure, I could have tailored that to the endoflip too, to get it down to a range that was, that looked good.
Yeah.
But
Can I-
also, I wonder about long-term. So one of the things in the study with the longer myotomy on the cardia was that they actually immediately all did well, whether it was 1.5 or 3, but long-term, they showed that there was more long-term failure rates. So I don't think we know that by tailoring to endoflip. Was just one thing I wanted to also say.
Yeah, well, and I think the other component too is that if you are extending proximally, I mean, the blown out myotomy thing, and especially in someone coming in here where they're not really dilated yet, you know, it's that, I mean, that's a risk factor. And so I think, yeah, tailoring it as much to the the area of pathology, I think remains an important component. And yeah, I think, yeah, on the gastric side, you're probably more worried about reflux rates, but going proximally, I think that from a GI physiologist standpoint, it always was kind of confusing to me, like why we would extend 6 centimeters for a sphincter that's maybe 4 centimeters at most. So yeah, I think that's another thing that we're watching, and I think there's gonna be more coming out on this blown out myotomy risk is an important factor to try to avoid.
And last thing I'll just say, so you were talking about DI greater than 3. So are you desufflating for this?
So no, so
Okay.
that's the thing, I'm doing a change, I'm looking at the change, and that's another good point. Like,
Yeah.
how much, if I'm staying insufflated and in reverse Trendelenburg,
And it's a long catheter, right?
and it's no, this is an 8 millimeter
Oh, it is 8?
catheter. But how much, right? I think it's the 8 millimeter.
70 milliliters total, isn't that your?
No,
It says AVMM up there, yeah, you're
I'm an 8, yeah. In intraoperative, I usually use an 8 because I'm just looking at the G junction. But how much is that affecting my numbers, my absolute numbers? Do we know? Like, is it going to go up, down if you're insufflated and in reverse Trendelenburg? Anyone? Yujiki's not here anymore? Okay, that's fine. My next case hopefully is here because if I get to it. But anyway, this was just one of those things where we're really pushing the envelope on surgical dogma and hopefully changing it with EndoFlip. If I have, yeah.
We were just talking, Mark and I, and one of the things that we, as general surgeons, foregut surgeons with a smaller length myotomy, and we don't know this right now, but you could potentially be setting yourself up for a diverticulum by not having that long myotomy and actually causing more of a
Pressure.
high pressure zone in that area.
Possibly. Yeah, I don't know. I don't.
If
And
you release the muscle well, though, hopefully not. Like if there's no obstruction and the
distally.
LES is relaxed, I would hope not, but it's a good point.
Yeah, well, and that's actually what I think the counter to that is that with that, that defect that's created by the myotomy, and that's what I talk about as a blown up myotomy, and that's a pseudodiverticulum. And we see those a lot as a cause of failure, cause of symptom recurrence, bad regurgitation, dysphagia. People who have had myotomy, it becomes like a diverticulum. So that's kind of,
So I'm
the
gonna
two
go-
edges to
if-
that sword a little bit.
Do we have time still to do a little bit more? Okay, good. Oh, yeah. Yeah. Yeah, I mean, I think if you have a perforation in the myotomy, closing it, recognizing it and closing it, usually those patients don't have ongoing leak. And then do a leak, I would do a leak test too, like insufflate with the thing, make sure that it's closed appropriately. I think I'd still be okay, the pressure of the plus or minus EndoFlip at the end, I'm not sure. I haven't been in that scenario, I'm not sure how comfortable I'd be inflating after I closed it, so I might not, I might skip it.
Yeah, no, I'm a little skittish with it. I've seen enough mucosal trauma with the device in that setting. Never a full perforation per se, but I've put it down, done the measurement, and seen trauma or a tear, and then just kind of like wrapped up the operation based on the old ways of visually being happy with it. Because too many instrumentations, I think we're pushing our luck a little bit. Yeah.
This next case is really to illustrate how experience matters, how trust in the technology matters. You'll see I just showed a case where I trusted it completely to change my surgical dogma. You'll see in this case, I become a bit skeptical and it just starts to interfere with my decision making. So you'll see that, and I'm going to show it, but I think it's important for anyone starting to bring this into the operating room that has limited experience. So I'm 77-year-old female with diabetes, lupus, atypical GERD symptoms, hoarse voice, sensation of food particles getting stuck in the upper esophagus, very little reflux on PPI therapy. She has very little reflux. She is on PPI therapy that doesn't seem to help her symptoms, and the patient does have an incidental hiatal hernia seen on a CT scan in an outside hospital. She is not complaining of acid reflux. She's not complaining of regurgitation or dysphagia. necessarily. She has some pill dysphagia, and she's saying that her biggest concern is her hoarse voice and her cough, and that is what she wants to be worked up for. And so her biggest thing is like, I have this incidental right hiatal hernia. Is it causing my hoarse voice and my cough? So I do an endoscopy, and at this point, I don't have the images to the CT. It says moderate to large. I don't know what that means. EGD shows a 4 to 5 centimeter hiatal hernia. This is going down. You can see the G junction. That's going down the esophagus. I'm looking at the gastric folds coming through the diaphragm. So large hernia, AFS grade 4, and it's a tortuous distal esophagus. Going into this, I didn't know what I was going to find, so I did the Bravo. The Bravo was pretty much negative. It was 2 of 4 days were positive. Total dyspnea score was 23, but if you really looked, the first 2 days were completely normal, moderate reflux on the other days. Does that mean I'm not going to fix the hernia? Probably not. If it's symptomatic, this doesn't matter to me very much with a 4 to 5 centimeter hernia necessarily, and her main issue wasn't reflux anyway. But I do consider that, because if she only wants me to fix her hoarse voice and her cough, and this might not be reflux related, I don't know that I can promise that. And then she did have a veg that showed contrast delay of passage in the stomach with mild reflux and a large hiatal hernia. Manometries showed an LES pressure of 38 with 100% intact swallows, peristalsis, and DCI of 6,000. That LES, this is like that EGJ outflow obstruction, but she has a large hernia. She has some pill dysphagia. I'm not thinking achalasia, but I was like, I'm gonna bring the EndoFlip into the room just to confirm that my suspicion is that EGJ outflow obstruction is from the hiatal hernia and will likely go away afterwards. So I'm gonna bring you to the OR. We have a large hiatal hernia. Oops, sorry. This is the initial EndoFlip. Again, and Mike, I'm gonna call on you in a minute, but I'm insufflated and I'm in reverse Trendelenburg position. And this is my initial, this is before dissection. I have a diameter of 9.1 and a sensibility of 1.4 in the setting of this high EGJ outflow obstruction type of picture. But how much does insufflation and reverse Trendelenburg positioning affect my absolute numbers?
Yeah, well, so interesting. Reverse Trendelenburg doesn't matter. It actually, the pressure and the diameter change to the point where the DI actually doesn't change. If you go flat or reverse, the DI stays the same, even though you do see changes in the pressure and the diameter. But they change in such a way the diameter doesn't change.
Good.
So that doesn't matter what position you're in. Insufflation makes a big difference. And I think that, when people say to me, we're getting different, we're getting like lower DIs than you are, but we seem to be having good results. Almost always it's because they're taking with insufflation. We had a consensus group, and that first white paper that was published in surgical endoscopy, we purposely chose to get desufflated numbers so they would match the GI positions in the GI lab. We are not insufflated in the GI lab, so we didn't want to have two different numbers. But so many people, and I know with the robot it can be hard to desufflate, we're going to have to also include some insufflated numbers, which we have. But the difference is going to be anywhere between 0.5 and 1. That's a big difference. So you shoot for 3, but you're getting 2 in here. It really is insufflated. It probably really is about 3 or 2.5.
Okay.
So
Yeah.
it does make a big difference. Insufflation makes a difference.
Good. And it's gonna decrease your numbers, likely.
Insufflation's going to decrease. It's going to
Yeah.
increase your pressure.
Right, but decrease the
So
numbers.
you're going to see decrease. And the other thing I would say here is, and you're maybe going to get to it, but I don't want to spoil it. But what you're getting at the beginning of the case is irrelevant. Like I wouldn't even measure this.
Right.
And the other thing is was mentioned by I think Zach, sevoflurane inhibits esophageal peristalsis. So if you're going to get pneumometry in the OR, you have to do it under TIVA, total intravenous anesthesia, or even in the GI lab, if your anesthesiologist decides to intubate somebody under general, you have to tell them no gas. It has to be TIVA, propofol only. That does not inhibit peristalsis. Neither does paralytics actually, but
Nice.
TIVA does. And so if you're going to get pneumometry at the beginning, I would not rely on the DI or the EGJ. Characteristics don't matter because this hernia is probably causing that.
Right.
And I think that's why you have to wait till you reduce the hernia when you measure the hernia.
And the SIVO concern is just the panometry, it is not the EGJ.
Correct.
Correct? Yeah, just so, yeah. Right.
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 Yeah. I reduce the hiatal hernia and I straighten it out. And I do a repeat endoflip at this point, still in reverse Trendelenburg and still insufflated. And I get numbers like this, 11.6, DI of 2.6. And right now I'm very comfortable that this was from the hiatal hernia and I'm not going to do a myotomy or anything of that nature, which I wasn't planning on doing that to go in. But I want to show you what happens next is when things kind of spiral, and you'll see in a second why. So I get done with I've had a beautiful repair so far. I am comfortable. I don't need to do a myotomy. I continue to do my closure the way I normally do. It's pretty tight around the esophagus, but no constriction. I do a very gentle wrap because she had that pill dysphagia. It's a Watson, it's anterior. The gentlest wrap I know how to do. And I'm like, we have the endoflip, let's look at it, let's see what that looks like. And I got a DI of 1.4 and a diameter of 9.3, but I'm still insufflated and in reverse Trendelenburg, but this is where I start to not trust, and I don't trust my experience. And up till this point, I had dabbled in bringing this to the operating room to tailor to tailor fundos. I really hadn't done it. I had done it once or twice, just to be like, oh, look, cool, it's in range. It's in that 2.5 range to 3 that we see in the papers, fun. And now I'm getting this, and I'm like, oh my gosh. I'm like, do I change anything? Do I take out stitches? What am I gonna do? Is this similar to what I had before? And I start questioning the protocol, and I'm like, does the numbers go up or down when I'm in insufflation? And I don't know, and I'm trying to recall the papers, and I start distrusting this number, and I start distrusting the endoflip, but I also feel like I have to act on it, and I'm not sure. So would you act on this? Would you change your procedure? Would you take out stitches? What would you do at this point?
I think this looks pretty good. If you unplug your insufflation on the robot, it's actually kind of nice because your robot ports you can still see. Mm-hmm. So it kind of like keeps the abdominal wall away. And I bet if you turned off your insufflation, I bet you'd be happier. Mm-hmm.
I'm trying to convince myself not to intervene on this. So I do the endoscopy. I had the endoscopy in the room, and I look at it. It looks good. And I start not trusting myself. I start not trusting the numbers and the endoflip, and I decide I have to take out stitches. So then I take out stitches. By the way, it's a running stitch, and if you cut a running stitch, then I'm afraid it's going to unravel, and then I'm putting in at the bonds to try and secure that. And I look at this, and now I have good numbers now on the endoflip, but I didn't show them, but my hiatus is so loose. If you let go of the tension, I have a huge gap there. I took down the whole wrap, and I am very frustrated. And I'm like, this looks horrible. And my endoflip looked better, but I'm like, this looks so bad, I can't leave it like that. I'm really frustrated. Kelly was in the room, my rep, and I was like, get this thing out of here. And then my next endoflip, by the way, once I did this, looked like this, and I was like, all right, I am done, I can't do this. And I go back and I'm like, take that thing away. It is messing with my brain. I am going to just go back to what I do best, and I fix it. And I ignore the endoflip, I take it out of the room, and I fix it, and I put it back to pretty much the way it was at the beginning. And, but it caused me a lot of stress, and a lot of extra time, and a lot of questioning all my decisions in the operating room. And I feel like this is an experience that you could all have if you're questioning the catheter, the numbers, your experience, and your confidence with the device.
Yeah, so, Mike's going to talk after the break about the protocol and some of the tips and tricks to this and the learning curve. But this is an important example as you're adopting. I've had similar experiences where you have to have a measured approach, and you've got to be, as always, we try not to treat numbers. We try not to treat images, right? And think for yourself, and don't, as Kaylin very vulnerably showed us, don't get overwhelmed by the numbers betraying you. I've had similar experiences. So, and that's not to say that it's not a trustworthy device, but it is just one part of the algorithm. And so as you adopt some of what Mike's going to detail later, you've got to have a little bit of buffer in mind, and he'll probably talk about some more nuance to that too, and how we've experienced that.
And then just super quick, so I'm a serial balloon popper. I tend to like rip it on the teeth, and something that Chris Zimmerman pointed out to me. So compliance is your tip off that something's wrong. So if you're getting numbers that don't make sense and there's no compliance being read, be suspicious that there's a malfunction or that you popped the balloon, because you won't get an actual number. So that like that last one you showed, I
Yeah,
wonder
that
if like
last
you're
one,
up there,
it
you're
was
like
just- I
jamming
was
it down and you're so
probably-
angry about everything. Like I've done this
Yeah,
many
the
times.
last one I broke the catheter. But in the beginning, like you said, it was probably fine in the beginning, and those numbers were probably a little lower because I was insufflated and I didn't desufflate. But I couldn't remember if when I was insufflated, if those numbers were falsely elevated or falsely like lower. So it's just, I think it's a really good way to illustrate like knowing what you're gonna do if you're gonna bring this technology in. Are you gonna trust it? I trusted it the first case, but my experience kind of failed me, and I didn't trust it in the second one.
Yeah, I mean, in painting years of story, we want everyone not to go through the learning curve that we did, because this is exactly what we went through for years, actually, until we really figured out what the right range was, and now we won't go through this anymore. We need to do a better job of educating everybody. I mean, today is part of that, but we know so much more now than we did, and we've been doing it since 2013. We had once we started to get an idea of what that range should be, we started ones that it's extreme to. But I think a few things. Number one, I mean, the insufflation is a big deal. I actually think your first numbers with insufflation will probably right
Yeah.
in the normal range. And I will accept DI over 2, even though the best range is 2.5 to 3.5. If it's just under 2.5 or just above, I think it's okay. I mean, there's some variability with the balloon. The other thing, two things, is energy. Monopolar energy will ruin the balloon. I mean, it messes with the conduction. And so if you use any kind of monopolar energy around, that might be why the balloon looked like it did.
At the end.
Showed it again. It'll just stop working. So you cannot leave it in the esophagus. Even deflated, you can't leave it near any energy.
Right.
Bipolar is okay. That's why you could use bipolar energy when you're doing like a heliomyotomy, and they won't
Yeah.
serve it. But monopolar energy will. And that could have also, and then the other thing is a balloon pop is that.
Yeah.
So if I'm getting, it's like, I think Dusty said this earlier, like, we all do this every day. And you have to interpret, do you act on a white count that's 13, pulse off 81? Absolutely
No,
not.
right.
Because you know that that's just reactive and probably doesn't mean the patient has an infection. Could they have an infection? Maybe they could, but we interpret numbers in a clinical situation, and you have to do the same with this as well. So if something doesn't seem right, check the balloon first. Sometimes the balloon has a little leak. And if the balloon has a leak, you're going to get bad numbers. Or make sure that all of the sensors are working, which you can usually tell by interpreting the, I'll show some slides on that.
Yeah.
But, don't believe the numbers 100% either if they don't make clinical sense. So we'll sometimes get rid of a balloon and put a new one in if it doesn't make sense. Everything looks perfect, and I don't trust it, but I don't want to leave the OR knowing that I'm outside of the range. I'll put in another balloon.
Yeah, and we did talk earlier that if you unplug the catheter and you can still use monopolar, but you have to unplug it. So yeah, thank you. I'm really excited for your talk. I think this was just to show that inexperience and some kind of that self-doubt that can creep in when you're using a new technology and not trusting it. And I know that I love EndoFlip, you guys, and I use it very routinely in my other cases, and I thought this highlighted really well that you need to know a protocol. You need to understand exactly what those numbers mean, and hopefully we'll get that with Yujiki's talk, so thank you.
Awesome, thanks, Laura. So let's take a break. Let's keep it tight. We'll just do 10 minutes. A lot of people kind of have flights they're feeling anxious about. So at 10:30, we'll get the next set of talks going, and we'll do some potpourri. We'll do some intraoperative protocol, and then you'll have more question and answer time.
For those of you who are interested in any hands-on action, there's an EndoFlip machine actually right outside the conference room. So if you want to play with the catheter, take a look at the technology, it's right outside.